Respected Professor Manchanda sir, the Padma Shri Award from respected Indian government, Professor Dr. Subhash Chandra sir, all the moderators for this deciphering ACC and all the speakers for this deciphering ACC. On behalf of Corona Remedies, I welcome you all for one of the August CME program, which we do since last 3 years post ACC. It is the program where we discuss the different topics for physicians, keeping in mind, because many of our physicians may not be able to attend this ACC. But what are the latest discussion has happened in current ACC? We try to derive those topics, and with the help of respected directors as well as professors, we do this program. Yeah, Vidhi.
Please start teaser.
Once again, on behalf of Corona Remedies, I welcome you all. I am very lucky enough to introduce our course director, Professor Dr. S.C. Manchanda. Though he doesn't require any introduction, but he has got some great honors from different faculties and specialities. To start with, he is awarded Padma Shri, one of the most prestigious award by the President of India. He has a Lifetime Achievement Award from CSI, and he has done original research work in high altitude problems. Apart from the medicines, he is also expert and a mentor for lifestyle modification through yoga and meditation. He has over 400 scientific papers and national and international journals. He is author for 50 chapters in standard medical books, including the Orum's Clinical Heart Disease book in the year 1999. And he is editor-in-chief for the Journal of Preventive Cardiology. He is chairman for World Academy of Spiritual Science and Divya India Foundation. With this, I hand over the session to Padma Shri Professor S.C. Manchanda sir.
Thank you. Friends, it's an honor to be course coordinator for this important CME named Deciphering ACC 2025 and Indian Perspective. You all know that cardiovascular diseases have a lot of advances which are occurring at a very rapid pace. Whatever used to happen in 10 years is happening in 1 year. And whatever is happening in 1 year is happening possibly in 1 month. And now with the AI possibly, we will be every day having some new research. This new research has really changed our practice. I remember when about 50 years back when I started cardiology practice, the cardiology was completely different. The diagnosis, the management, etc. was completely different. It has changed over a period of time. Now, there are so many advances which are available to the physicians that physicians get confused. But the best research is presented in the ACC, This is American College of Cardiology, which is held every year. And this is actually an international conference, although held in America. People from all over the world present their latest research. And not only the latest research, but there are late-breaking trials which have a big impact on the clinical practice and all. Those of you who have attended, there's a lot of confusion there also if you attend the conference because you have to run from one hall to the other. And it is difficult to decipher which one to attend. And in the Indian perspective is not very clear in many of these. So I think this is a very good initiative, CME, one of the best CMEs initiative which has been taken by Corona Remedies, which will decipher ACC 2025. About nine articles have been selected, which have a significance to the Indian clinicians, and I'm sure that many of these will have impact on our clinical practice so that it can improve and all. As you know that every year now research is so much that the new guidelines are being developed now, which will be discussed today, and many of the chronic coronary artery disease problems which are there, the management has completely changed, will also be discussed in this. So these 9 articles have been very carefully selected so that the general practitioners can improve their practice and all. And to address these 9 subjects, we have very eminent and excellent teachers from all over the country who will be discussing about these different subjects. We equally eminent are the 3 moderators who will be running the show. And without taking much time, I think this will have a big impact on the clinical practice and all. And I am sure that this CM is going to be very fruitful and very educative to all of us. So without taking much time, I would hand it over to the first moderator, who is none other than Dr. Subhash Chandra. I think Subhash Chandra, I know him for a long period of time, more than 40 years. He was with me in All India Institute of Medical Sciences. I happened to teach him also. He's one of the most brilliant students of All India Institute of Medical Sciences, and he worked as faculty member, and he has worked in several other institutions. He's a leading interventional cardiologist and an excellent teacher also. And I'm sure that he will conduct this first module in an excellent manner. Only my request is that I would request the speakers that they should keep to their time so that we can have very interesting discussion, because I want to make it that the general practitioners should ask lots of interactive sessions should be there at all. So without taking much time, over to Subhash Chandra.
Thank you, sir. My heart is always filled with humility whenever I share podium with my revered teacher, Professor Manchanda. And as he rightly said, our association goes back to 40 years ago when I entered AIMS as the medical student for DM cardiology. And he was the most revered teacher for all of us. And it's all because of his blessing that we have reached so far. So without much ado, sir, the endeavor from Corona Remedies has to be lauded, because this is one effort where the dissemination of information and updation of knowledge is the aim. And that is very necessary for all of us as medical fraternity to do the whole justice to our patients. We should keep updated with the new knowledge. So without much ado, I would invite our first speaker, and I'll be responsible for conducting or moderating these 3 first modules, which are very interesting. They're dealing with different aspects of cardiovascular disease, as in the ACS or the lipid management and the preventive aspects. So without much ado, I would invite Dr. Gautam as our first speaker. And Dr. Gautam hails from Mumbai, and he has excellent credentials to his credit. So Dr. Gautam, without much ado, let's start and kick off. Upload your presentation and let's hear you. Thank you.
To be speaking in front of stalwarts. Our field and opportunity to talk to all of you today. Again, point pertinent and important, sir mentioned, is that to get the best of ACC, into the current guidelines and how to extrapolate them into our day-to-day practice is what we are trying to do. Information is so vast that again, running from pillar to post and going through 10 different journals and various articles, and here in the next 15 minutes I'll try and do justice to the latest update in the management of lipid. Can I have my first slide, please? Yeah. Yeah. What really has been happening is treatment for lowering LDL and ApoB beyond statins. We started really in 1995 with the 4S trial, and we've come a long way now. Whereas we were very happy in high-risk patients to have our LDL of around 130 to now very high-risk patients where we are recommending that the LDL level should be below 30 milligram per deciliter. The next slide, please. So from 1995 to now, there has been a paradigm shift in the lower, the better. So when to use non-statins, whom? The patients who cannot get to their goal. When do I use it? Maxed out on statin therapy, cannot tolerate statin therapy. Why should I use it? Well, the data shows that lower LDL, lower non-HDL is consistently linked with a lower MACE. What are the drugs in my armamentarium today? Non-statin ones which I can use: ezetimibe, bempedoic acid, PCSK9 inhibitors, monoclonals, and the siRNA, which we will be talking about. The next slide, please. So here, coming to ezetimibe, what it really does, it inhibits the intestinal absorption of cholesterol, increases the synthesis of LDL receptors. More the LDL receptors, more the LDL clearance. It's a orally bioavailable drug, cheap and easily available, brings about a 15 to 20% reduction in LDL from the point where we are going to start when used alone. Brings about a 25% reduction when used in combination with a statin. The IMPROVE-IT trial results, again, very, very heartening. It showed that around in 18,000 odd patients, the LDL levels in simvastatin and ezetimibe combined group was baseline approximately 53.2 versus 69.9. And needless to say, 3-point MACE was definitely better in the individuals in whom simvastatin was used along with ezetimibe. The next slide, please. The next slide. Yeah. So bempedoic acid, again, another new molecule. What it really does is two-pronged attack. So one side, it reduces the biosynthesis of cholesterol. Just a second, the slide, yeah. And it increases the synthesis of LDL receptor, increases the LDL clearance. Again, it's orally bioavailable drug. 20% reduction in LDL when used alone, 15 to 20% when used along with a statin, and a good 35% reduction when used in combination with ezetimibe. The next slide, please. So the trial which was shown to us, yeah, the next slide, yeah, around 13,700 odd patients, ASCVD or at a high risk and unable to take statin. Either they had maxed out or intolerable to statin. Primary and secondary prevention data at 40 months of follow-up, when the baseline LDL was around 139, around 102 milligram per deciliter was achieved. The next slide, please. And needless to say, right, that the clear outcomes, yeah, the next slide, please. The clear outcomes went ahead and showed us that again the 4-point MACE overall morbidity mortality re-MI rates in individuals who were on bempedoic acid over and above the standard statin therapy was better. PCSK9 inhibitors, now actually these have been the game changers. What PCSK9 is really, it sort of brings about the breakage of LDL receptor. So if we have PCSK9 inhibitors, so more number of LDL receptors will be expressed on the liver, and hence more amount of LDL from the bloodstream can be cleared off. So here we have a PCSK9 inhibitor, that is evolocumab, in the Fourier trial. 27,000 odd patients, very high risk, with a 3.4% ASCVD per year, 34% 10-year risk. So who were on guideline-based high intensity or moderate intensity, they were followed up for a period of 2.2 years. The LDL reduction as early as 6 to 8 weeks was 59%, which led to a huge drop in overall MACE and re-MI rates in the patient in whom PCSK9 inhibitors were used. The next slide, please. Right, again, the Odyssey trial, similar kind of results were seen. Recent ACS patient followed up for 2.8 years, the baseline LDL being 103. LDL levels achieved were 66 milligram per deciliter on these PCSK9 inhibitor, and hence the MACE and overall event rate in individuals on PCSK9 inhibitor over and above the statin was definitely better. The next slide, please. Inclisiran, again, it's a small interferon RNA inhibitor. Again, it inhibits the formation of PCSK9. So the LDL receptor longevity and expression is more. Once every 90 days, the injections are done. The Orion 10 and 11 and a phase 3 study is going on again, Orion 4, and the results are pending. But however, the results have gone ahead and showed that there is a significant drop in the LDL as compared to where we initially began with in patients who were on statin, who are at a very high risk of event within the next 6 months. The next slide, please. So how do we really approach the patient to addition of non-statin therapy? Now, individual LDL cholesterol target would be based on the patient profile. No cardiovascular outcome, hard data is yet awaited. So what we really recommend for all our patients is an adult with an indication for lipid therapy or on maximally possible tolerated dose of statin. Now, if there is to come an AC after come back, and we need to get the LDL down to really less than 70, now targeted beyond 55 to 70. In those individuals, we would be considering additional drugs, if not then PCSK9 inhibitors, to ensure that our LDL levels are below 55. The next slide, please. If we talk about HDL now, right, it's like a U curve and has been mentioned. Too much of a good thing or not enough. Next slide, please. And why do we say that? Next slide. Why do we say that? Because there is an inverse relationship between low HDL and MI risk for the statin group and control. So regression analysis suggests that low HDL effect on MI risk is not overcome by statin use. So you're going to get your LDL really down, but if your HDL also falls to the boots, then you are in trouble any which ways. The next slide, please. Unfortunately, as of today, we have very few drugs which would lead to an increase in HDL. So what we have to do is lifestyle modification, right? That is regular aerobic exercise, stop alcohol intake, low carbs, of course, the other medications, insulin, niacin, anti-epileptic drugs. All these are investigational and would bring about marginal increase. And a very interesting fact, again, a large number of our patients do come in, say 5 to 10% now we are seeing with very high HDL levels, so markedly elevated, right, are usually conferred with an increased risk of ASCVD and should be kept in mind. The next slide, please. So if we have to talk about really, the next slide, yeah. Right, so therapies which are targeting, again, like we said, niacin, the AIM High trial, which was done in 2011. However, there was no significant reduction in MACE despite increased HDL levels. Same thing according to HPS2 Thrive trial, which was done in 2014. The various other trials with CETP inhibitors too have not shown a significant reduction in MACE despite increased HDL levels. The next slide. So really, should we target therapies to increase HDL? As of now, data suggests otherwise. The next slide, please. Triglycerides too play a very important role. Yeah, so will CETP1 answer really the questions? We have various trials which are going on with this drug, right? And we have been able to show an increase in the HDL levels, reduction in LDL-C and LPA levels. Really, will it translate into better outcomes is what needs to be seen. Again, the query will be, if we have a drug which will reduce the LDL and LPA significantly, are these benefits because of reduction in LDL and LPA rather than an increase in HDL? Well, it's for anybody to guess, and we need to wait for the result of these trials. The next slide, please. Right, cholesterol efflux, again a therapy which came out that if we are able to throw about, or we are able to extract cholesterol from the intracellular, get it to the liver and purge it out of the system, will it really lead to a reduce in cardiovascular events? The next slide, please. And hence, of great interest came up, the next slide, please, that drugs which will really lead, you give the infusion of human recombinant ApoA1, right? And what it will do is sort of intracellular cholesterol and to which will take it to the liver and bring about the degradation and excretion of the LDL. So if your LDL levels are going to fall to the boots, again, your outcome would improve. But there was no significant difference between placebo and the ApoA1, which was used similar in the AGIS 1 and now the to bring down LDL levels intracellularly and in the blood, definitely is really not known. Initial trials, of course, have shown it not to be of much benefit. The next slide, please. I'll quickly take you through the triglycerides. The next slide. Next slide. So really, yeah, lifestyle and pharmacological therapy for hypertriglyceridemia. The next slide. Triglycerides play an important role, right, in bringing about all the pathophysiological changes and enhancing atherosclerosis, as we all know. The next slide, please. So we have traditionally we have had drugs like fenofibrates and gemfibrozil and niacin, and impact of triglyceride level beyond LDL lowering in ACS. It's one of the most important post ad hoc analysis which supports the independent association of increased triglycerides with CV events, especially in the Indian population where we have mixed dyslipidemia. So targeting and getting LDL to goals alone is not going to be of great benefit. Greater benefit would be to get triglycerides down to the targets also. The next slide, please. So here what we do, the traditional drugs we have along with lifestyle modification. The next slide, please. This we all know, I would not talk too much on paucity of time, walk, diet, exercise, cessation of alcohol, aerobic activity, reduced adiposity, all. The next slide, please, would bring about lowering in the levels of triglycerides. However, pharmacological, what we need, the next slide, please. And now we have in the reduce it trial is icosapentaoic, which is used as an oral drug. And when used and studied in the clinical trial in the reduce it showed that risk of ischemic events was lower when with icosapentaoic when used as compared to placebo over and above the standard therapy. The next slide, please. Right, again, the evaporate trial, icosapentaoic acid, the effect was studied on coronary atherosclerosis, though a significantly low number of patients, that is only 68 were studied, but it went ahead and showed us that on statin therapy with persistent elevated triglycerides, placebo versus icosapentaoic ethyl when used showed plaque regression. The next slide, please, as is shown in this, the next slide, yeah. And it was the first study which really went ahead and evaluated the plaque volume changes in patients who were on this drug versus placebo arm were significantly different. So IP plus statin was associated with a slow rate of progression, not only slow rate of progression, but also with plaque regression as compared to individuals in the study who were on statin plus placebo. So if your patient is not achieving triglyceride the targets and it makes sense to start this drug to begin with itself rather than wait for 3 months and ensure that your LDL is down to the target and then consider reaching the triglyceride goal. The next slide, please. So I think with that, I've concluded my talk. If there are any questions or at the end of the module, we can take. I think we are running late. We started late, but I think I finished on time.
Excellent, Dr. Nilesh.
Thank you, sir. Thank
you have touched on so many newer aspects, and I'm sure our audience is going to be benefited immensely. What is the plan, the strategy? Should we take a few questions now, or should we finish all the 3 modules and then come on it? Because
we will finish all the 3
I think
modules,
all
then
right.
we will go for the questions.
So I'll invite Dr. Arun now for the next talk. Okay, Dr. Arun hails from Mysore and needs no introduction. So without much ado, please start your presentation, sir.
Yeah, thank you, sir. Thank you, Dr. Subhash Chandra and Dr. Manchanda. It's a great pleasure to be amongst all of you all again. I'll see if I can share my slide. Okay, so are my slides visible?
Yes, sir. Slides are visible, sir.
Okay, sir. Thank you very much. Now, I'll be speaking. The next topic is on daily dilemmas in the management of stable ischemic heart disease. The first point for discussion here is, of course, coronary calcium. And we all hear a lot about coronary calcium, especially from the patients. We all want to have their CT angiogram to know what their coronary calcium is. So what do we do with it? What do we do with the data and how do we use it? Okay, now the traditional risk factors perform well at population level. We know that if we have a large population with diabetes, hypertension, etc., we know the risk is higher. But they perform less individually. Okay? If you look at an individual patient, you do not know exactly what to do. So coronary calcium score integrates multiple factors: the risk factor, exposure intensity, duration, genetics, and lifestyle. Of course, the newer ACVD risk estimator, the prevent data we know is very useful for risk stratification. Of course, we have a lot of other data available. Now, coronary artery calcium, there is a class 2A indication for evaluation and risk factor stratification. Now, the risk spectrum and coronary artery calcium, if you see, for we know for primary prevention, anybody with already has a clinical event, we call it secondary prevention, and there is something known as a 1.5 prevention, not primary, not secondary, or 1.5 risk prevention. That is for those with advanced subclinical atherosclerosis. Here we use coronary artery calcium, and anybody with a coronary artery calcium of more than 300, we put them on aggressive treatment as much as secondary prevention. That is the ACC recommendation at present. Now, coronary artery calcium and statin therapy guidelines. Now, CAC has prognostic value among statin users, although association is not very strong. If you take those with coronary artery calcium 0 as the reference level, those with a score of up to 100, if no statin use, the risk is 1.8 times. With statin use, it comes down to 1.3. A score of 100 to 400, if the no statin use, risk is 2. With statin, the risk comes down to 1.5. And a calcium score above 400, without statin, the risk is 5.3 times. And with statin use, it drops almost by 50% to 2.4. You will see there is a lot of overlap in the range, but still, if you look at the average, there is a significant reduction in CV mortality with use of statins in those with large coronary artery calcium above 400. Okay. Now, in the Jupiter eligible participants with a LDL of above 130 and HSCRP of above 2, the number needed to treat with zero calcium was 549 patients. Any calcium present was 42, and with a calcium score of more than 100, the number needed to treat was only 24 for a 44% relative risk reduction over 5 years with the use of statin, which is very significant. You can bring down the events by 44%, close to 50% by starting them on statins over a period of 5 years, which is a very important lesson for all of us. Next is the ESPRIT trial, which looked at 11,000 participants, mean age of 65, 40% females, those with increased cardiovascular risk, more than 2 risk factors. Almost 40% had diabetes, 27% had previous stroke. So significant cardiovascular disease. And primary outcome of death, MI, stroke, and revascularization, heart failure, hospitalization came down significantly with reduction in blood pressure from a goal of 140 to a goal of 120. Okay, there was a 12% reduction in outcomes with pressure to 120. So there is a strong recommendation that you should bring down the blood pressure as close to 120 as possible. Similarly, in the BP road trial, 6,000 participants, all with diabetes and one additional risk factor. 23% had cardiovascular disease, 45% were females. Primary outcome of non-fatal stroke, MI, heart failure, hospitalization, or CV death. Here again, bringing down the blood pressure from mid 130s to 120 with intensive treatment. Okay. Decrease the hazard ratio by more than 20%. So here again, it is important to remember that we need to treat blood pressure aggressively. And the present recommendation, just like LDL cholesterol, is to keep it lower and to bring it as close to 120 millimeters systolic as possible. So if there is prevalent coronary artery calcium, initiate statins. Okay, what next? Okay. Along with statins, if the calcium score is more than 100, discuss antiplatelets, also intensive BP control as we just mentioned, and get LDL to less than 70 for sure, and those with a high number of risk factors, you try and get it to 55. If the coronary artery calcium score is more than 300, especially if it is more than 1000, intense lipid lowering to as low, LDL as low as less than 55, and along with that, to look at other things like we just discussed, ecosap pentythyl, GLP-1 receptor agonist, and of course, optimize lifestyle, predominantly look at the cardiometabolic disease, lifestyle changes, weight reduction, etc. Now, advanced lipid lowering, one look at non-statin lipid lowering therapy, especially those with a calcium score of above 1000, high intensity statin, get the LDL to less than 70 as much as possible. In such cases, it is reasonable to consider ezetimibe and PCSK9 inhibitors, as we just mentioned. Okay. Now, non-statin therapy, GLP-1 receptor agonists again are important for those with a BMI of about 27 with or without diabetes. If you look at the overall population, you do a cardiac CT, look at all the whole population together. Now, number needed to treat with semaglutide over 3.3 years to prevent race was 247, and the obesity related first event was 98. And those with a high calcium score of above 300, you prevent MACE by treating 79 patients, and the first obesity related event, the number needed to treat is down to 37. So again, GLP-1 receptor agonists are again an important set of medications for us now, for those with the BMI above 27, especially if they have coronary artery calcium. So coronary artery calcium estimation for those with obesity, diabetes, and other risk factors is of course extremely important, and you should treat them aggressively with statins, treat their blood pressure aggressively, and get their weight down with semaglutide. That is the present or the recommended standard of care by ACC. Now, next thing is, if you have a blockage, why won't stenting make these blockages make me live longer? So let us look at a couple of trials. One of them was the Courage trial. These are trials which will look at revascularization versus medical therapy. Courage trial, 2,000 patients between 1999 and 2004, followed up for over 15 years. And during an extended follow-up of 15 years, no survival difference between initial strategy of PCI plus medical therapy versus medical therapy alone. This is, of course, for a very selective set of patients. Angiogram findings more than 70% stenosis in epicardial artery. Exclusion, okay, those with class 4 angina, strongly positive stress test, refractory heart failure, cardiogenic shock, EF of less than 30%, recent revascularization within 6 months, and anatomy not suited for PCI. So if you exclude all these patients, a very selective group of patients, they found no survival difference between medical therapy and medical therapy plus angioplasty. Okay, so over a period of 15 years, stable IHD, angioplasty may or may not be helpful in a select group of patients. Similarly, in the ischemia trial, 5,000 patients with moderate to severe ischemia on imaging or severe ischemia on exercise testing without imaging, randomized 1:1 to initial medical therapy, angiography, and revascularization versus medical therapy alone. Here again, over a period of 5 years, no difference in MACE. And important thing is to look at exclusion criteria, recent ACS, unprotected left main disease of 40% or more by CT angiogram, EF less than 35, unacceptable angina despite medical therapy. So those with strong symptoms, left main disease and LV dysfunction were excluded. And in them again, no major difference in myocardial infarction over a period of 5 years in the ischemia trial. So no difference in primary composite outcome of all-cause death and of ischemic cardiovascular events with revascularization. Now, prognosis of MI type in ischemia. Here, randomized total of 5,000 patients with moderate to severe ischemia. Invasive strategy 59%, PCI 20%, CABG 21%, no revascularization. In the conservative strategy, 14% has had PSI. 7% had CABG. Inclusion criteria: stable ischemic heart disease with moderate to severe ischemia, coronary artery disease more than 50% confirmed by CT angiogram, and angina control with medical therapy. Okay. Now, here this is a pretty busy slide. Okay. Now we need to look at a few important things here. One is goal attainment and cardiovascular death or myocardial ischemia in the ischemia trial. What are the things you should look at in the guideline directed medical therapy? Systolic BP should be less than 130, LDL less than 70, complete smoking cessation, and aggressive or good antiplatelet therapy. And all goals met versus no goals met. If all goals met, the incident dropped more than 50% over a period of 5 years compared to no goals met. If you do not achieve any of these things, then of course you do not get good result. But with guideline directed medical therapy, if you achieve all the goals, bring your blood pressure down, LDL to less than 70, and stop smoking and use antiplatelet agents in the ischemia trial within a selected group of patients, your MACE drops to more than 50%. Next, coming to the revascularization recommendation. Now, class 1 indication, those with multivessel coronary artery disease and LV dysfunction, CABG is recommended to improve survival. That's a class 1 indication. And those with similarly with multivessel disease and mild to moderate LV dysfunction, 35 to 50% EF, CABG is reasonable to improve survival with the use of a Lima graft. Recommendation is class 2A. For left main disease, with those with left main disease more than 50%, CABG is recommended to improve survival. That's a class 1 indication. Those are the only two class 1 indications: multivessel disease with LV dysfunction and left main disease of more than 50%. It's a class 1 indication for CABG. Similarly, left main disease for those with anatomy suitable for PCI. PCI is a reasonable option to improve survival, class 2A indication. Multivessel disease, normal ejection fraction. CABG is reasonable to improve survival, class 2B. Again, angioplasty is class 2B. Proximal LAD and revascularization to improve survival is uncertain, class 2B, which is again little surprising because in our practice we always use proximal LAD stenosis, significant stenosis with documented ischemia as a indication for revascularization, whether it is angioplasty or bypass surgery. Here it is for stenosis of proximal LAD, it is given 2B. No benefit or class 3 indication for those with 1 or 2 vessel disease not involving the proximal LAD. Revascularization does not improve survival. Similarly, stable ischemic heart disease with the coronary anatomy stenosis less than 70%, FFR more than 0.8, revascularization not recommended because it can in fact cause harm. And patient with stable ischemic heart disease, multivessel coronary artery disease, appropriate for CABG or PCI. Revascularization is reasonable to lower the risk of CV events such as MI or CV death. Again, it's a class 2A indication, multivessel disease. Okay. Lastly, in patient with refractory angina, despite medical therapy with significant coronary artery disease, revascularization is recommended as a class 1 indication. So these are some of the things which have come out of ACC. And conclusion wise, on the basis of a currently available high quality data, revascularization in the setting of stable IHD without left main disease or multivessel disease does not improve all cause mortality. Optimal medical therapy, including smoking cessation, aggressive control of lipids and hypertension, antiplatelet therapy, and antianginal therapy, are the first line in the management of stable IHD. There is a debate on the role of revascularization in reducing MI and future CV death in stable IHD. And in patients with stable ischemic heart disease and angina, refractory to medical therapy, revascularization should be explored. Now, just a couple of slides on stress test. Okay, we all do stress test on a regular basis for screening. And if we say stress test was low, do we say no problems and let them go? No. Okay, we'll just look at an example. 30-year-old lady with extreme obesity and on medications for hypertension, diabetes, family history of heart failure, no addictions. Most important thing here is the BMI was 53.5, 128 kilograms, and lipids were okay. We would probably want it lower, but they were not really too bad. LDL of 97, a normal ECG. Bruce protocol, she walked up to stage 2 only 3.5 minutes, reached 93% of heart rate, hypertensive BP response, dyspnea, as expected. Okay, but no, there was no ischemic EC changes. 4 years later, had new exertional dyspnea, LV ejection fraction had dropped. So she was initiated on heart failure therapy. Mild coronary artery calcium score of 50 only. So again, extremely low risk. So for ischemic events, so she was started on diuretics for heart failure medications, and that treatment continued. Okay. Next, looking at some of the important thing on stress test. We always say stress test negative and send them away. Couple of things which we need to understand and talk to our other physicians who do treadmill. We should remember a few important points. One is the functional capacity. If the functional capacity is poor compared to a functional capacity being good over a period of 2 years, okay, 3,400 patients studied, endpoint all cause death, strongest independent predictor of death was fair or poor capacity. It means somebody who cannot walk 6 minutes, the incidence of all cause mortality is significantly higher over a period of 2.5 years. Okay. Next thing is ECG changes. Now, 250 consecutive patients without coronary artery disease. They had no obstruction on CT coronary angiogram or on myocardial perfusion imaging. Looking at the type of the ECG changes, they can have ischemic changes on ECG on treadmill, and those who had significant ischemic changes on treadmill during exercise and during recovery persisting for more than 1 minute of recovery, this you would definitely call a significantly positive stress test. And even in them who did not have coronary artery disease, they had events. That means they had uh, coronary microvascular disease, coronary flow reserve of less than 2. And in such cases, especially if you pick them on a PET CT, and those with obesity, you definitely had much higher incidence of events. Okay, so even with a normal coronary arteries, those with decreased myocardial reserve, you can have a high range of events. Okay, so what are the important things to consider? Functional capacity, note poor or fair functional capacity, that is less than 6 minutes. ECG changes, ischemic changes in spite of having a normal epicardial coronary arteries, their prognosis is poor. And amongst all of them, PET CT is supposed to be the test of choice, especially for those who cannot exercise or those who have high risk factors for coronary microvascular dysfunction, including cardiometabolic disease. Thank you very much. And I hope I have not exceeded my time too much. And with this, I hand it over back to the chair for treatment. Thank you, sir. Thank you very much.
One caveat to that would depend on the type of stuff. Type 0 with how much of that
Should I stop sharing?
Yes, sir, you can start.
Sorry, I have not been invited, but I think I am supposed to say. So should I start?
No, Dr. Sunny, we are just waiting for you to start up. Please.
Yes, please.
Please. Yeah.
So we are supposed to talk about this new ACS guideline, and there are multiple facets into it. I try to cover the areas which are appropriate for us. Most importantly, what it comes is the diagnosis of acute coronary syndrome. Now, over a period of time, what we have understood very clearly that we get more of a non-ST elevation myocardial infarction in the outdoor setting, not talking about those patients who are extremely sick with a acute MI with either an electrical disturbance or a pump failure masquerading into an acute left ventricular failure. They go to definitely the hospital or emergency medical care. But a vast majority of the patient who comes with some doubtful ECG changes and we cannot compare with the previous one. The most important challenge at the present moment is to rely on the biomarker. We have seen a couple of times that biomarker, if it is done too early, it becomes negative and we don't do the biomarker second time. And ultimately patients come into a large myocardial infarction after 24 hours with already a damaged left ventricle. So the new biomarker needs to address specificity and sensitivity wise within early hours of myocardial infarction, as early as 0 to 2 hours. So this is the new concept, and probably we'll get new kits in the future which will help us. This is a jumble of site, but again, my focus on non-ST elevation MI today, in view of the fact these patients were particularly a low risk patients or intermediate risk patients. They come with ambiguous symptom, and many of them attribute it to the GI symptom. What we need to regularly practice, at least I try to practice many times, the gray score and TMD score. Now, these scores are available in the smartphone. A gray score of more than 140 put you into a high risk non-ST elevation MI. So if we recapitulate the gray score, it takes some important variable, that is the age of the patient, renal function, hemoglobin, and the systolic blood pressure. Now, if you calculate those score in elderly patient vis-a-vis a younger patient, it will be invariably higher. So the take-home message is very clear that elderly patient, sorry for the sound, I just tell somebody not to make sound. So the take-home message is we should not deprive elderly people. How much food should we eat? So elderly people should not be deprived of this benefit of early revascularization. That is important. And TME score actually takes very few variables. So gray score still is the gold standard to identify who are the high risk and who are at lower risk of non-ST elevation MI, where you can wait till next day to take them into the cath lab. Now, another concept has come, many a patient who has a existing known coronary artery disease managed medically or by any other means, and now they are going for a non-cardiac surgery. Do you need to check routinely a evidence of myocardial infarction? So this is again, the thing is, if a patient who is high risk and you can do a troponin T in 24 and 48 hours after surgery to identify myocardial infarction. Particularly this happens with a transplant surgery or a major surgery where the patient being not been coming out from circulatory support or ventilator or requiring inotrope. Otherwise, there is no point of routinely measuring this thing. But definitely, if there is a crescendo value of this biomarker, you need to know that you have done something gone wrong during the perioperative period. Now, with all this thing in mind, that point of care testing should be wearable. That's a myth, but probably an ST elevation MI you can get early, but in many non-ST elevation MI you may not get a positive result in a very early stage, and that's the reason we need more appropriate point of care. As of now, we rely only on cardiac troponin I and T, but there is another new molecule, heart type fatty acid binding protein, which is very specific, but its utility in the clinical practice has been less. And so we probably need to know after a few years down the line that how important is this.
Hello,
Have we lost the
Sunil sir?
connection? Looks like we
Part of
lost.
this for the session are
Can't hear.
Dr. Rajendra.
So you can repopulate your screen again.
I think I was disconnected.
Yes, sir. For a time being, you were disconnected. Please repopulate your screen and then we can initiate.
Yeah. Tell me where I got disconnected. This slide or?
Yeah, the slide is not showing, sir.
No,
Not
sir is
visible.
going to populate. Just hold on. Neeraj.
I do that. Is it now visible?
Yes, sir.
Yes,
It's
sir.
visible now.
Yes, sir.
So I talked about the biomarker. The basic concept is that we need to get the biomarker at the early hours so that we don't get the myocardial infarction in very early hours. Particularly, this is for high-risk non-ST elevation MI in nuts. And more appropriately, when this recommendation of angioplasty comes, as our previous speaker has said, the options, those are for the chronic patients for elective procedure, but for in acute coronary syndrome, we mostly think that you need to fix all the blockages which seem insignificant. And this may be done in the same hospital setting It may not be in the same table at the time of index procedure, but should not be deferred for a more ischemic guided or physiology guided therapy. Except for patient where you think a artery which is a large caliber artery and the doing angioplasty may jeopardize patient hemodynamic, you should defer and send them for a stage bypass surgery. And the important thing is what are the supportive medicine. I am coming to that. Before that, it is important to know that if you do a complete revascularization, you actually don't incur major bleeding, you don't incur more renal injury, rather you decrease the CV death, myocardial infarction, and repeat revascularization over a period of time. And these are pretty latest data. Now, why it has happened? Because of very active antiplatelet drug, and in 2025, we all use ticagrelor because we know its rapid action, predictable antiplatelet activity, and it is reversible. After 48 hours, you stop it, action vanishes. So the take-home message should be any patient who is coming with a non-ST elevation MI, and if you are in doubt, treat them. At least if this patient is not having a bleeding inside active, which your clinical judgment should decide, this patient is not going to harm. Rather, giving a clopidogrel will be a drug which will deactivate the platelet than the ticagrelor. Prasugrel is only being used in patient who will going to have a stent. So that's why if you see this data, that more of myocardial infarction with STMI, they receive prasugrel because you know you are going to do a primary angioplasty. But in non-ST elevation MI, you may need to send the patient for CABG, and where if you give prasugrel, next 7 days you cannot do a incision on the chest, and that's the basic difference. As far as the effectiveness of these two molecules, they are both very powerful antiplatelet drug, except the fact that prasugrel should be avoided over 70 years of age and whose body weight is less than 60 kgs and who had previous cerebrovascular accident. Now, our many patients are less than 60 kgs, so probably that's the reason we are using this prasugrel, but it doesn't mean that we will not use it. Now, it's important to give it early. In our country, we don't have the luxury of using Impella in most centers. So do we need to have a prophylactic IABP? The kidney doesn't support a IABP or a ECMO in patient with AMI less than 40% ejection fraction, and then do the angioplasty. So better that we have to do all these high-risk patients with the high-risk consent or leave them on medical management. Now, Paradise myocardial infarction MI trial did not show that giving ARNI is going to have a benefit to the patient. Ultimately, they will be going to Paradise if you don't do an appropriate job for myocardial infarction treatment, that is revascularization, as soon as possible. So despite all these things, there will be some patients who will have progressive decline in ejection fraction. And in next follow-up, if you find this patient's ejection fraction is dropping, you should consider starting ARNI to prevent adverse remodeling. So this is a proof of concept. EMPIRIC trial again reduces hospitalization, but due to heart failure. So those who are at risk of heart failure, you can give, but prophylactically giving it post-MI has not been shown to be decreasing the event rate in future. There's a lot of event trial with these combinations, and we all know, we read that GLP-1 receptors are agonist based, but from patients who are taking their complex still is a question mark, and probably over a period of time the compliance will increase, we hope. But in this subset of population, there is no evidence that GLP-1 agonist in acute coronary syndrome is important, even if the patient has diabetes and obesity. Colchicine, to be or not to be. So in this New England Journal of Medicine, just 4 years apart in 2020 and 2024, there is two diagonally opposite result came up. And if you go into the detail of this trial, it says only one thing, that if you have a large myocardial infarction, the mortality remains high whether you give colchicine or not. But if the patient survives and there is some residual disease here and there, and this patient survived the initial phase, maybe colchicine will be useful. But as a practitioner, none of us are routinely giving colchicine, at least I am not giving. But I don't know about my colleagues, how frequently they are giving. Cardiac rehab remotely in elderly patients is the smart approach. Even in younger patients, after a myocardial infarction, we have seen still the patient come in follow-up and saying that we are not allowing this patient to go out climbing stair. So we are to educate the society. Society has to come up before this rehab is in full swing in country like ours. So in summary, a transition to ARNI, if LVEF regions less than 35, pick them up, and if you give ARNI, I don't think there is any harm in doing it. Okay, it is costly, but now it is not like that. In all patients with acute MI, post-MI, if the patient is not on, and diabetic particularly, is not on SGLT2, please initiate it. This is a endocrinologist compartment. Probably they will be better able to address this thing. And we need to do a good dose of statin. And what good of statin is best is being. Can I have 1 minute in my hand?
Yes, sir. Yes, sir.
Fine. So in nutshell, what this 2025 guideline says, that bring down the LDL as low as possible, add non-statin lipid lowering agent, because you don't know how much is the tolerability of individual patient. And so these are all the previous and newer guideline. More complete revascularization is the approach now. And this is important, that you must individualize the post-DAPT, post-procedure DAPT continuation depending upon the bleeding risk. So if this patient is future bleeder, you have to decide at the table and you have to put the stent appropriately. That should be the smart approach. So for that, you need to have a adequate knowledge of primary PTCA intervention strategy. Many times we put a undersized stent, many a time we are tempted to do a big size stent, we don't do a post dilatation, and many times we use stent which has no evidence of single antiplatelet therapy after some time. And non-statin therapy is the present and the future, because if you wanted to decrease LDL by 50% in this high risk population, whatever rigid diet you give, it is not the appropriate approach. So probably after reading this presentation, what we are doing, we'll be doing the same. Probably we'll be more aggressive in recognizing AMI and not to miss any patient. Second is we need to be more focused in giving antiplatelet drug at the beginning without wasting time. This data doesn't mention about giving heparin before taking the cattle into the catheter, but this has been in practice in some center, including in my center, where we give heparin at the emergency, and as we do already in most of these cases, bleeding is not an issue. And individualization of DAPT post-MI is important. AMI with heart failure is not in the guidelines, so there is a gap of knowledge on these areas. So a myocardial infarction which present with acute LVF may recover, then you may treat it in not like a heart failure patients if you think that really the patient has recovered. But many patients will have a scar, and if you don't give appropriate remodeling therapy at this stage, there is no point in watching the patient is having an ejection fraction of 40, 35, 30, and then getting LDL. I end it here. Thank you.
Excellent, Dr. Suneet. You have, in fact, gone beyond the purview of these presentations and have given really practical tips as to how to manage the ACS in the current times. I think all the three speakers have done justice and highlighted the important aspects of how they have evolved in the newer guidelines in the ACC. So, Professor Manchanda, sir, what would be the plan now? Because we covered three aspects on these three talks: the lipid management, the prevention, and now the ACS.
Yeah, you can ask for any questions, etc., or maybe give your comments if you want to.
So, if I have to summarize, as much as I recall, in last 1 hour, regarding lipids, we were surprised to see that there's a U curve for HDL also. That excessive of HDL, which is found in few individuals, is bad. So that was one aspect. The utilization of non-statin therapies in the armamentarium of antilipid therapy was an important aspect. The infusion of ApoA1 as a novel way of checking out cholesterol from the system was another thing. Lipoprotein small a was not covered in the talk, and I'm sure drugs like the pilacarsen and all are in pipeline, and they would give us sub-guideline as to how to manage those individuals with familial hypercholesterolemia or high lipoprotein small a, besides hitting the LDL cholesterol. That was important in the first talk. In the second one, I was amazed to see that individuals having more than 300 of calcium score are eligible for secondary prevention, where aspirin has a role, whereas people with just more than 100 calcium score would just be okay with lipid therapies. And then various aspects of secondary prevention, as in the obese patients who have underlying high risk for coronary artery disease, could benefit by giving them GLP-1 receptor agonist, was one very important aspect. Colchicine has been out of favor in the latest data, and a lot of emphasis on the lifestyle management when it comes to triglyceride management. And of course, there's some data on the EPA, which we saw in those presentations. And in the last one, where Suneet touched upon how the high sensitivity troponin should be utilized, at what intervals it should be done, which is conventionally anything between 1 to 3 hours or so. to hit every non-STEMI patient, and then risk stratifying non-STEMI subset, because there's some inertia in dealing with non-STEMI. I think we should be more aggressive once we come across a high-risk patient with non-STEMI, and we should follow the invasive strategy. There was some talk about the conservative approach in courage and ischemia trial, but that as such has been a lot of cloud, and one has to dissect it out also. That invasive approach is any way better. Role of bypass surgery in eligible patient with left main and TVD, especially proximal LED, was the way. Downgrading the PCI guidelines in the proximal LED to 2D was my concern, which I'm sure would be clarified in the coming years. And of course, Dr. Saneep went out of purview to talk about the antiplatelet therapies and the shock in acute MI and overutilization of mechanical support like Impella or IDP in these patients was one very important aspect discussed. So this is my summary of what I gathered from these three talks. Sir, rest is up to you. You can highlight any aspect which I not covered.
Are there any questions in the chat box? Any questions from the audience?
I don't see any question.
Okay. I think all
We
these
can
three
wrap it
speakers
up, yeah.
did an excellent job. As you said, I think all these three speakers gave us new information, as you said, about the lipids, lower the better, and the effect of triglycerides. And I was impressed by that regression of atherosclerosis by eicosapentaenoic acid also when you combine with the statins in that COVID study. So I think that was absolutely new information, and it will be very useful for our patients and all. And as was said by third speaker also, that we should try to reduce the lipids as soon as possible after myocardial infarction, more than 50%. And as you see the latest CSI guidelines, my colleague Dr. J.P.S. Sani has written those guidelines. 50% reduction is not possible in about 30-40% of patients after myocardial infarction. And therefore, what they have suggested is to add non-statin ezetimibe with the maximum dosage. That may be the future for myocardial infarction, that you start both the drugs simultaneously so that you achieve more than 50% drop. I would just like to make a comment about lifestyle management. A lot has been talked about it. That's my interest also. But one thing is missing from lifestyle is the stress management. And there are several studies available in which stress management has been done by yoga and all. We talked about the rehabilitation after myocardial infarction, and a huge study done from India, which was published in JACC and as a late-breaking trial presented in the American Heart, showed that yoga-based cardiac rehabilitation after myocardial infarction is equally good as the usual rehabilitation, and it is cost-effective and should be tried. It is possibly going to come in the guideline. There's a single study, but in 36 centers from India, and this is very, very important. So I think the Indian context, I would like to say that we should add yoga also after myocardial infarction. So there's a very good study available in JACC, and it is a very huge study. And secondly, when we talk of lifestyle, apart from the smoking and all, we should talk of the stress also. I think all these three speakers have done extremely good job, and it will help us in our clinical practice. Thank you very much, Subhash, and all the three speakers. I think now we move on to the second module because we are running behind time. And the moderator for this second module is none other than Dr. K. Jayashankar, who is very well known. Dr. Jayashankar is here?
Yes, sir. Morning, sir.
Morning.
How are you,
Jayashankar is extremely well known, very senior cardiologist, electrophysiologist, interventional cardiologist, and an excellent teacher. So I think he's going to moderate this session, which has also three interesting papers. So over to you, Jayashankar.
Thank you, sir. Thanks very much for the warm introduction, and glad to be part of the deciphering the ACC yet again, sir. And thanks, Team Corona, Mr. Tushar, for having me again. We are running behind schedule, so I will not take much time in the introduction. We have three very important talks. I had the opportunity to go through all the three talks, and fantastic. And I'm sure the speakers are going to do a great job. So now I invite Dr. Kamal Sharma He's going to talk to us, take us through some ECGs, and he's got an exemplary academic background. He's a senior interventional cardiologist, interested in structural interventions, a lot of publications to his credit, plenty of coronary interventions, has had some important awards to his credit. So, and he works in Ahmedabad at the UN Mehta. So, Dr. Sharma, would you be happy to take over and take us through?
Good morning, everyone. Thank you, Dr. Jaishankar, for kind words and introduction. So, as you mentioned, this is more of interactive one. I hope the audience can come in and type the answers in the chat box. So, what we're going to do is go through a couple of ECGs, not exactly on the lines of what is late breaking in ACC, but Corona wanted me to actually talk about some interactive ECG interpretations. So I wish that we can get some comments from the participants and the audiences alike in the chat box as to what these ECGs are. I'll try to run through some of the ECGs pretty quickly so that we can have some time for discussion. Some of them may not be the classical ECGs, but these are the ECGs that we are going to share and discuss with you. So this is a 62-year-old man, diabetic hyperlipidemia, acute onset of chest pain. So any comments in the chat box as to what this is? I'm going to give you some clues. You can look that the ECG is, of course, broad complex, and there are some STT changes. So if you can see what we are dealing with, it's a wide complex, sinus rhythm, and some STT changes. Anyone? Basically, this is Smith-modified Garbosa criteria for an LBBB acute myocardial infarction. The criteria one is concordant ST. Normally, you would expect the STs and the Q wave and the ST elevation and the T inversion not to be concordant. They would be discordant in presence of Burden branch block. But if there is ST elevation, which has now been modified, previously it used to be Garbosa criteria of 5 to start with. Now it's just 1 millimeter. And so concordant ST elevation 1 millimeter, if it's not discordant, that itself should give you a clue. And of course, if there is concordant ST depression of more than 1 millimeter, would also qualify as a modified Garbosa criteria. Criteria 3 being ST elevation to S wave ratio of 20.25 in leads with discordant QRS complex. So this is what we were dealing with. I'll take you back to the ECG and you can look at the segments where you can see the discordant and not only ST elevation in the mid-precordial leads, but the AVL and the lead 1 and V4 all are suggestive of an acute myocardial infarction. Presence of even Q waves in presence of LBBB is a good clue to identify myocardial infarction in presence of LBBB. Apart from the criteria, so those two were the new modification. I thought we'll take care, interpret this ECG. If you can have comments in the chat box again. Case number 2, 45-year-old women depression treated with escitalopram or citalopram, recently started on azithromycin for bronchitis. Episodes of dizziness, palpitation for last 1 week with no chest pain or dyspnea. I think that gives enough clues. You have 1 SSRI, 1 antibiotic, and dizziness and palpitation. Any clue as to what we are dealing with? Look at the ECG. Of course, there's a rough rule that can help you guide into what we are dealing with. When you're looking at the duration of the QRST, though usually you would go with the corrections. I'm giving you a clue for the heart rate. You need to correct those intervals. Anyone in chat box? Either everybody knows the answer or nobody knows it. So it's either ways. It's an all or none phenomena. We are not getting any comments on interaction. But the simple way to look at it is roughly when we were taught by our teachers is that make sure that the QRS to QRS duration, the T's don't fall beyond 50%, though this may not always be necessarily be true. You need to correct corrected QT interval Besset's formula, or otherwise, depending on the heart rate, as we know, if the heart rate is less than 60, Besson doesn't hold that much true. So this is acquired long QT. Basically, a prolonged QTC of more than 440 or 460 in men and women, respectively, would qualify as a long QT. And that's likely to present with arrhythmia, proarrhythmic events. Here, it is more than 500, which is associated with Torsat. So long QT need not always be congenital or genetic, as we call it. It need not be genetic channelopathy. You can have acquired ones, and very often, most of the A's as in antibiotics, antiarrhythmics, antifungals, and antidepressants, are responsible for prolongation of QT. Escitalopram causes is less likely, but citalopram is more likely. Tricyclics were even worse. tricyclics along with macrolides, or even for that matter, antihistaminics would give rise to a deadly combination in a patient who's got a borderline QT interval, and it would be further compounded by drugs which can cause hypokalemia, and then that would be a very nasty cocktail to present with a Torsat. So this is a acquired long QT. Very often you'll find this in a patient who has been on multiple concomitant medication, has got some borderline electrolyte issues with some other therapy ongoing, like a diuretic in some cases. Very often, it need not always be a cardiac patient, but it can be a non-cardiac patient presenting with long QT and acquired long QT and history of syncope. Coming to this third case, a 55-year-old smoker, hypertensive, episodes of chest pain over the last 24 hours occurring with exertion and at rest. He's currently chest pain free. Now, this is very commonly seen. This is very often seen in our practice. Patient did not have any ST elevation, but this is the kind of ECG. Can anyone tell what is it?
I think there are no interactions, so you can.
Yeah. So I'll proceed with the explanation as well. Valence, this the valence A and valence B. This valence A is biphasic T. Valence B often presents with deep T inversions directly rather than biphasic. This basically is equivalent of an anterior wall or ST elevation MI. So ST elevation MI equivalence includes a valence sign. So this must be treated on priority. You have T wave changes which are symmetrical, biphasic, or deep T, depending on type A or type B. No significant ST elevation at time of ECG. Patient may appear clinically stable in between episodes, but high likelihood of severe proximal LAD, often 95 to 99 or even 100% occlusion. This is case for 25-year-old women, 48 hours of intermittent palpitation, lightheadedness, currently experiencing near syncope. This is a ECG 6 months ago. This is, I think, a very often asked spotter in a lot of entrance exams. Irregularity reveals what it is, and you have intermittent narrow QRS complexes. Look, if the irregularity is too much to give out, it's often a case of atrial fibrillation. But when there is wide complex and there are delta which are revealing it, it's a pre-excitation. So pre-excitation with an atrial fibrillation, with a conduction and antegrade conduction on the bypass track is the revealing finding. And that's the pre-excited atrial fibrillation, fast, bizarre, irregular, FBI as they call it. Caution would be to use AB nodes, because then the conduction would not be on the AV node. The all conduction would happen across the bypass track, and these patients can go into ventricular fibrillation. Very often you need to cardiovert. That's the best therapy. Of course, a lot of times they ask you as an MCQ what's the drug of choice, but more on that. If the patient, if in doubt, best is to cardiovert. Maximally pre-excited QRS coupling, interval yield, important information. Postromedial accessory pathway, as was documented in this patient, and memory T post-ablation can also be documented. This is another 38-year-old man presenting with 2 episodes near syncope and 1 syncopal episode, all at rest without warning. And this is pretty interesting. Very often you may think it as normal or myocardial infarction, but look at V1. In a patient with syncope, don't miss out your lead V1. Look at V1 and you look like what is called the AVR elevation here, the pattern of ST elevation in lead V1 isolatedly. It's a channelopathy of Brugada. Brugada, remember, is common in Asians, nearly 1 in 500. This is not so rare. It's probably as much as the occurrence of hypertrophic cardiomyopathy, which is again 1 in 500. So a lot of patients actually pass through our sites. If the brain doesn't know, your eyes don't see. So channelopathy, this is often familial clustering, ST elevation in V1 to V3, cold ST shape. Remember, type 1 is the one which is classical. This is the one that needs to be addressed urgently. 2 and 3 may not be identified as classical ones and need to be provoked. Provoking factors can be fever, antiarrhythmics, tricyclics, cocaine, hypokalemia, and a lot of times these patients can have sudden cardiac death. 65-year-old man, near syncope, failed PCI to LAD 2 weeks ago, EF of just 20% after late presentation to cath lab. This is the ECG, and blood pressure is 80/50. Heart rate is 150. This is interesting. You may think of it as a sinus tachy, but remember the rhythms lead V5. You're not seeing the classical QRS relationship, not the classical. It's basically, this is basically infarct and development of anterior aneurysm in the patient presenting with ventricular tachycardia. Remember, not all VTs are broad complex. There is AV dissociation. If you can see lead B5, the P waves are falling after the QRS complex, and the aneurysmal VTs may not always be a wide complex VT. So narrow complex VT, you should always be watchful for. Narrow due to proximity and entry into the conduction system. The farther it is, more wider it is, nearer it is to the conduction system, narrower it is. So Q in RV1 is suggestive of VT from the proximal LAD infarct post septal perforator, and QNST elevation leads better seen in VT than the sinus rhythm. And that's why this is, you may not think it as just a healing anterior wall MI. You should always be watchful and think it as, if you don't mind, as they call the principle of Churchill's law P, mind your P's. If you don't see your P's, you're dealing with something else. So try to find the P's in the AV dissociation. If you see that, you've clinched the diagnosis very often. So this is a case of ventricular tachycardia in an anterior aneurysm, and aneurysm have AV dissociation with fusion beats and also presence of AV dissociation classically seen in the rhythm beat. This is another ECG, 65-year-old men, chronic kidney disease, recent gastroenteritis, decreased oral intake, presents to ED with lethargy and weakness. If at any point of time, if there are some participants keen to answer, I'll be more than happy to look at that. But for the sake of time, I'll continue. This is hyperkalemia, bizarre sine wave complex manifestation, classically seen in hyperkalemia. This is sine wave complexes. You can look at the undulating baseline. And in patients with more than potassium of 6 terminal QRSP, wardens with notching, slurring, left axis shift because of late LV activation. Hyperkalemia will reduce amplitude, increase the phase 0 of action potential with slowing of the conduction. And ST segment will be merged with the QRS and T waves, slowing the ventricular activation with further flattening of P and prolongation of PR interval. So this is how the changes will revert. And when you start treating hyperkalemia, they will narrow down. And only the first change that you usually find when the potassium exceeds 5.6, less than up to 6.2 is the tall T waves. It's only beyond 6 that most of the times, and again, the ECG changes may depend on other electrolyte abnormalities if they're present or absent. This is another ECG, 68-year-old recently widowed women presenting to cardiology clinic to obtain the results of a cardiac MR because of inconclusive echo. She has chest pain, palpitation, shortness of breath, no history of head injury. This is very often missed out as ischemia or missed out as left ventricular hypertrophy, isolated benign left ventricular hypertrophy. But remember, this kind of asymmetric deep T wave inversions in the chest leads, it could be apical hypertrophy. A lot of times you look at an echo done where they've ruled out basal or the SAM or the ASH by looking at the basal septums. A lot of variants actually have isolated pure apical variants, and you may actually miss it out unless you've looked at the apical full chamber, or if you've looked at the short axis, you had the apex cuts. So you need to look at a broad differential in T inversion, myocardial ischemia or hypertrophy, or the Takotsubo apart, hypertrophic cardiomyopathy, IC bleeds, and T wave memory in the patients with the electrical activation during pacing. These are the important causes that need to be ruled out. This is another ECG, 58-year-old women, recent myocardial infarction, presenting to emergency department with shortness of breath and chest discomfort, vitals of 90/60, blood pressure, heart rate of 115, heart sounds muffled, JVP, jugular venous distension is present, and she appears to be in acute distress. This is the ECG, again, a broad complex, but look at the P waves, look at the ECG QRS complexes. The P waves are not changing in the amplitude, but the QRS is changing in the amplitude. This is what is electrical alternance. Alternate electrical beats are tall and small. So this is a classical feature of tamponade. So cardiac tamponade, pericardial effusion, you can get patients with what is the classical Beck's triad, whereas hypotension, muffled sounds, and JVP distension. Regular rhythm with times with pulse, and management is urgent. You need to put pericardiocentesis needle in quickly, or recurrence, then you can think of window. And of course, you need to treat the underlying cause. A lot of times it may be post-PCI small bleeder accumulating fluid around on the blood from the perforator that might have been missed, or a perforation caused by a wire in some of the patients. So this is another case, 70-year-old women presenting to ED with dizziness, shortness of breath. State the next best intervention to treat the primary cause of a presentation. Look at the ECG. Remember, all like escape rhythms need not be broad. You can have narrow escapes, and then look at the P waves, as they say, Churchill's Lapi. Look at the P waves, they are AV dissociated, more P waves than the QRS complex. This is, however, reversible bradycardia, acute ischemia, dominant RCA, Lyme's disease, RC, you look at the ST elevation in lead 3 more than lead 2. So this is right coronary artery. Inferior infarction related bradycardia often improves once you revascularize. You need to be quick, but of course you need to put a temporary pacemaker. A lot of times these patients can get into cardiac arrest. And this is the blood supply for the conduction system. For the sake of time, I'll move to quickly the case number 11, 76-year-old female, stage 4 CA colon with liver mats, worsening LFTs, paroxysmal AFib on flecainamide, presents to ED with diarrhea, vomiting, chest pain, electrolytes are within normal limit. Now, this is very often with the availability of flecainamide as a drug in our therapy, we end a lot of patients with underlying structural abnormality may be prescribed this therapy and actually end up with flecainamide toxicity. So flecainamide toxicity, it's a potent latent channel inhibitor, phase 0, say slowed down. Toxic levels can cause the PR prolongation and QRS widening. It's metabolized both liver and kidney. So patients who have impaired liver kidney function, 7% of Caucasians are slow metabolizers. We don't know the data for Indian subsets. So always use the combination. Don't just rely on therapies like flecainamide in the long run. Flecainamide is good as a pill in pocket. Sometimes in structurally normal young patient, you can choose this as a long-term maintenance therapy. But again, it's off-label. But in a patient elderly who has got a structural abnormality, it's not a good drug to be. So thank you very much, Dr. Shankar, for the opportunity. I hand it over back to you. Thank you very much for patient hearing to each one of you.
Thank you very much, Dr. Kamal. It was indeed wonderful listening to you showcase some real-life ECGs and clinical presentations, which are not uncommon in daily clinical practice. Unfortunately, there has been no interaction from the audience, but it was nevertheless a very good teaching session. So is there some question coming up during the panel discussion? I'll probably request you to stay back so that we can attend to it. Now I request Dr. C.K. Ponde from Mumbai, who's a senior interventional cardiologist from the Hinduja Hospital. Can I have his introductory slide, please? So he's going to take us through the often forgotten right side of the heart, the right ventricle in pulmonary hypertension. He's again a very he heads the invasive and non-invasive cardiology department at the Hinduja Hospital. A very astute interventionist and plenty of teaching to his academic achievements to his credit. And I would request him to take us through the right ventricle and what we miss and what we should not miss. Over to you, sir.
Good morning, sir. Can I share my... Sorry. Can you see the slides? Hello?
Your slides are on HFpEF?
Yes, sir. We have the slide. Sir, his topic is changed just yesterday. I think tech people have not added in the system. But
right. Sorry, I was not aware.
Yes,
the one
sir.
shared to me is on right ventricle. Okay, please go ahead, sir.
Yeah.
Can you see my slides, sir?
Yes, yes. Please go to the slide mode, the slideshow mode.
Okay. So I'm today talking about the diagnosis of HFpEF. This is a universal definition of heart failure. Reduced ejection fraction is very easy to diagnose, as you all know. Just get an echo done, and if the ejection fraction is lower than 40%, it's HFrEF. However, patients who are breathless, who are congested, and yet have normal ejection fraction, it is difficult to diagnose whether it is HFpEF or some other cause of their breathlessness. And this new and revised classification we have seen is based only on ejection fraction. What is the prevalence of HFpEF? If you look at this is the previous data from 2012 by Steenberg, and you can see here as many as 1/3 of patients across the globe, right from 2005 to 2010, had heart failure with preserved ejection fraction. However, in the recent times, after the Asian Heart Failure Registry, which was published, and later on the GBD Disease Injury Incidence and Prevalence Survey, which was published in Lancet 2017, and later on again, an addendum was made in 2021, almost 50% of patients worldwide who suffer from heart failure have preserved ejection fraction. And what about clinical outcomes? They are not vastly different. Even if ejection fraction is normal, once you have heart failure, their 5-year and 8-year mortality rates are not vastly different. They are more or less the same. HFpEF was defined by heart failure symptoms with a normal or near normal ejection fraction, which is more than 0.50 in men and more than 0.55 in women, or 50% in men and 55% in women, first described by Dr. Lucci in 1982. But this cutoff does not exclude mild systolic dysfunction, which was diagnosed usually in nowadays laboratories by global longitudinal strain, GLS. Some of the physicians listening to this talk may not be aware of this, and I will show you some slides for that. The term preserved ejection fraction is not probably perfect, because what has happened, there is a lot of dichotomy and lot of overlap in the randomized control trials of HFpEF, which have included patients with ejection fractions of 40 to 45% and above. Actually, those trials have a mixed bag of patients with mid-range ejection fraction and truly preserved ejection fraction, thereby creating a lot of problems in interpretation of the results of these trials. Moreover, the ASC, the American Society of Echocardiography, has further classified HFpEF as two types: those without structural heart disease, that means with normal global longitudinal strain, and those with structural heart disease, that is those with reduced global longitudinal strain. And these two reviews, one by Margaret Redfield and later on by Caroline Lamb, are absolutely stunning reviews of HFpEF for those who are interested. Is diagnosis of HFpEF difficult? I say not at all. It is challenging, but feasible in most cases. So this is a clinical score called H2FPEF score, H2FPEF score, in which these are the clinical variables which are given certain points. For example, if you are obese, given a 2 points. If you have AF, given 3 points. And being hypertension, pulmonary hypertension, elderly age, or elevated E by E prime on echo, which is a surrogate of pulmonary capillary wedge pressure, is given a point of 1. So if you have with these very simple scoring system, a score of 1 or less, HFpEF is unlikely. 6 or more, HFpEF is almost certain. And between 2, 3, 4, 5, that is 2 to 5, you need some more testing. Very, very, very simple score to apply in your clinical practice. Because when a patient walks into a room, you know his weight, you know whether he's hypertension or not, you know whether he has AF or not, and by echo, and you of course know his age, and by echo you know the E by E prime and the pulmonary artery pressure. Later on came the ESC score, which is a little more complicated score, but I think little more accurate score as well, where apart from the initial workup in the form of signs and symptoms, comorbidities, standard echocardiography, natriuretic peptides, etc., you go to echo variables. And here there are two echo variables and one biomarker, which gets a point of, these are the major criteria, of course, they get a point of 2 when they are into the upper bracket, pink bracket. So if you are E by E prime of more than 15, LA volume index more than 34, NT-proBNP of more than 220, you get a score of 2. So if you have total score of 4, more than 4, HFpEF is very, very certain. Whereas the E by E prime of 9 to 14, little lower, LA volume index little lower, 29 to 34, and NT-proBNP little lower, you get a score of 1. So if your score of above 4, diagnosis of HEP is certain. And as we know that these three criteria, relative wall thickness, LA volume index, and E by E prime ratio are the most important criteria to be looked into the echocardiography. I don't say TR does not need to be looked in, but the most important value addition criteria are relative wall thickness, left atrial volume index, and E by E prime ratio of more than 9. The relative wall thickness is given by doubling the dimension of the posterior wall and dividing that with a LV dimension. So 2 times posterior wall thickness divided by left ventricular dimension is the RWT, and the normal value is 0.32 to 0.42. Anything above 0.42 is considered increased relative wall thickness, which is one of the minor criteria for diagnosis of HEP on echocardiography. Of course, ASC has given many other algorithms. This is one algorithm in patients with normal EF and normal GLS. You study these 4 points: average E by E prime, TR velocity, and LA volume index. If any 2 or more of them are positive, you have significant diastolic dysfunction. And those with reduced EF or normal EF with reduced GLS, the algorithm is little more complex but perfectly practicable in routine echocardiography laboratories. Then the next is, are natriuretic peptides always elevated? Well, not so. As many as 30% of patients with HEP may have completely normal natriuretic peptides, and therefore they need advanced workup like stress echo or exercise echo. And I will show some examples of that. Then the next parameter which came in the guidelines recently is looking at the left atrium. And this editorial by Benjamin Fried on stepping out of the left ventricle shadow is extremely brilliant editorial, which says that you need to look at the left atrium, and left atrial mechanics alter or show the earliest abnormalities on echocardiography in patients with HEP. So the HEP algorithm on exercise is again the same, that if you have a PCWP by invasive tests of more than 25 in exercise, or here on echo stress, the E by E prime goes more than 17, you have a problem. So let us have a first case of mine, 56-year-old male, hypertensive, obese, non-diabetic, dyspnea for last 3 months, blood pressure 150 by 90, pulse rate of around 90. And you can see here, he has got concentric LVH, ejection fraction looks bang normal, but the left atrial diameter is 48. So left atrium is dilated. You can see here, ejection fraction looks bang normal, but the left atrium is dilated. And going ahead, the mitral E by E prime is 22, significantly elevated. Look at the E prime, grossly reduced, and the GLS is reduced to minus 16%, which is much lower than normal. The LA volume is 105 ml, and LA reservoir strain is reduced significantly. The normal cutoff is 34. Here it is around 30. And NT-proBNP is 1120. So if you look at our score, we have elevated E by E prime. We have dilated huge LA with LA volume of 105 ml. And we have NT-proBNP, which is much above 220. So you get around 6 points in the ESC score, confirming the diagnosis of HEP. This is another case of mine where a 48-year-old female, hypertensive, non-diabetic, weight of 72 kgs, progressive dyspnea over 8 months, and 3 admissions for acute decompensated heart failure in the last 4 months. So mind you, she's only a hypertensive, non-diabetic, little overweight, but not obese, and 3 admissions. You can look here, LV is very small, contractility appears normal, but look at the left atrium. It is huge left atrium with 2 laminar jets of MR. These 2 jets, parallel jets of MR coming from LV to LA, have no turbulence whatsoever. Now, if I ask the audience why there is no turbulence, because the left atrial pressure is hardly 100 systolic, right? And the LA pressure is grossly elevated. Therefore, LV-LA gradients are small, producing non-turbulent jets of mitral regurgitation. You can see here 2 jets of MR and there is no turbulence on color M mode at all. And if you see typical spike and dome pattern of mitral inflow with E by E prime of 22, you can see your GLS around minus 13, grossly reduced GLS despite a normal ejection fraction. So this is one HEPF with grossly reduced GLS. And look at the atrium. Left atrial volume is 120 ml and left atrial reservoir strain. Again, I'm repeating, the normal cutoff is 34 and here we have 7. So any left atrial reservoir strain of 18% or lower than that is considered a hallmark of HEPF. In this patient, NT-proBNP was 4,159. So clearly suggesting HEPF. Does HEPF shows different phenotypes? Yes. We have phenotype A where there are only exercise-induced symptoms. When there is a pulmonary hypertension and right heart failure, it is phenotype C which has got a worse prognosis. And phenotype B are the patients which I showed you earlier, the 2 patients. So there are at least 3 common phenotypes and we have now a typical lean diabetic, uniquely Asian phenotype. Here the patient is not obese, he is lean, he is diabetic with worst outcomes and worst quality of life. This particular lean diabetic phenotype of HEPF was from the Eastern Asia, particularly from the continents like Indonesia, Taiwan, and Philippines, and this is worst prognosis. The case of mine again, phenotype A. I repeat, phenotype A. 72-year-old gentleman, diabetic, hypertensive, near normal BMI, started having exertional angina. I did a stress echo, it showed inducible ischemia. So I did an angio, it showed proximal LED stenosis, underwent PTCA plus 10 to LED. 18 months after the angioplasty, started having exertional dyspnea. No angina. I repeated a stress echo, I will show you that. CT angiography showed patent stent. So this is a stress echo, resting image on dobutamine. Excellent contractility, 4-chamber view, then 2-chamber view again, resting and on dobutamine, excellent contractility. But what happened was, though the contractility was normal, at rest, his E by E prime of 9 on dobutamine, the E by E prime was 20. So this man has now developed HEPF. His coronary artery disease is taken care of, but now he has developed typical diabetic HEPF. You can see here, though his LVEF is normal, his GLS is reduced to minus 13, his NT-proBNP is 780, so it's clearly a phenotype A, typical exercise-induced symptoms in a patient with HEPF who has previously undergone a year and a half ago coronary angioplasty to LAD. Though now the stent is patent, ejection fraction is normal, he is breathless, he has elevated NT-proBNP and needs to be treated. So we treated him with dapagliflozin and ARNI and he has settled down. Do we need etiological workup? Some specific etiologies of heart failure that may be targetable must be identified. For example, this is a patient of mine where you can see ejection fraction is normal, but you can see the typical speckled sand appearance of the myocardium. Can you see that? Very typical speckled sand appearance here in the apical lateral wall and in the entire interventricular septum. Here also in the apical anterior wall, the speckled sand appearance, and E by E prime was 17, and the strain map shows typical cherry. Cherry is the apical strains are preserved and the basal strains are gone. So this is called cherry on top appearance, typical of amyloidosis, very typical of amyloidosis. And in this patient, though the global strain is reduced, the overall ejection fraction is normal because the circumferential strain and the radial strain by 3D echocardiography are completely normal. Then comes the role of MRI, because there are some myocardial histopathologic findings in HEPF, such as fibrosis occurs in close to 90%, hypertrophy in close to 90%, inflammation in around 13 to 14%, and amyloidosis in around 15%. So, CMRI is called the non-invasive cardiac histopathologist. And here you can see here the T1, the native T1 mapping and extracellular volume. For example, this is normal. In hypertension patients, you can see clearly that there is a diffuse myocardial fibrosis on a native T1 mapping and globally increased ECV, extracellular volume, in hypertensive heart disease. In Fabry's disease, the pattern is different. In amyloid, you can see that the native T1 values are dropped, are very high, and the extracellular volume is increased. So CMRI can definitely give you a non-invasive information about the cardiac myocardial structure, myocardial fibrosis, and extracellular volume. So please remember that evaluation of various LV diastolic parameters is different, has a different timeline. For example, LA reservoir strain changes the earliest. The LA volumes index starts increasing somewhere in the midway of the disease, and so also the resting E by E prime. However, the exercise-induced E by E prime again starts changing at a very early part of the disease. So if you want to diagnose LA HepPep very early, look at LA reservoir strain and look at exercise. Let the patient walk in the corridor for a period of 4-5 minutes. Again, check the E by E prime compared to the resting E by E prime. So all that I say, that we still don't know the exact phase of the HepPep. Until this time, we need to do our echocardiography in a very sensible way and very passionate way to diagnose suspected patients with HepPep. And almost half of the patients with HepPep will need CMRI at some point of time in their disease. Thank you very much indeed.
Hello, Jaishankar sir.
Hello.
Just a minute, sir. I hope Dr. Jaishankar sir connection is cut too. Maybe I'll just connect with him once.
Oh, thank you very much, Dr. Ponde. Sorry, my connection was a little unstable. I got lost and I'm reconnected. I think we'll have the questions towards the end. I'll now invite Dr. Soumitra Kumar, who's a professor and head at the Vivekananda Institute of Medical Sciences in Kolkata, and he's got an accomplished academic background. And as he said earlier, we won't waste time and request him to take over and take us through the advanced ischemic heart disease, the role of various MCS for our interventions and when to intervene. Over to you, sir.
Thank you, Professor Jaishankar and Manchanda sir, and my learned colleagues and members of the audience. Thank you, the team of Corona, for this invitation once again. And as has been the convention, I was advised to make a extempore verbal presentation on two very relevant topics in advanced ISD management. First, these were thrashed out in the ACC 2025. So it is very relevant to the ACC 2025. The first topic is current surgical options for ischemic cardiomyopathy with advanced LV systolic dysfunction. And the second topic would be the current status of CTO PCI management. So first, ischemic cardiomyopathy. Now, what is ischemic cardiomyopathy? I did not narrate to this august audience. It is, of course, related to coronary artery disease when we have severely damaged myocardium or severely weakened myocardium, damaged because of necrosis followed by scarring, and weakened either because they are severely ischemic or hibernating. And the EF generally we refer to less than 35%. Now, LV dysfunction, systolic dysfunction anyway has a high mortality risk. And if it is of ischemic etiology, it is an independent variable for a very high mortality. So we need to do something about it. We just can't leave it unchallenged. So the various options in our kitty at the present moment are either first, if the LV dysfunction is very severe, we think it is beyond revascularization, the trend has been referring the patient for cardiac transplantation, or providing some ventricular assist devices, if they are available and affordable, as either bridging therapy or bridging to the surgery, bridging to recovery, or at times as destination therapy. But now
Sorry to interrupt, sir. Are you having any slides? Because we are not able to see any slides.
No, sir, I was
Just next
advised
time.
to make a verbal presentation.
Okay.
Yes.
Okay. Go ahead. Sorry.
Okay. Hope I am audible and comprehensible.
Yes,
Yeah,
sir, you're
I'll
audible.
make it
Loud and
slow.
clear.
Yeah. So why it is contemporary now? Because we are thinking of CABG as an option for these patients with advanced LV systolic dysfunction and underlying ischemic etiology. Now, CABG, of course, plus minus surgical ventricular restoration, plus minus mitral valve surgery, be it repair or replacement. Now, first of all, what is the problem with cardiac transplant? It is, of course, a kind of a gold standard therapy for these kind of patients. But the problem is the scarcity of donor organs and the financial issues and the logistics associated with it, which makes it not available to everybody. And then advanced stage multiple comorbidities doesn't make it an option for them. And then there is the risk of subsequent immunosuppression. So, as a matter of fact, ischemic cardiomyopathy comprises of 30 to 45% of patients receiving cardiac transplant. So, this 30 to 45% of patients, there are many others who actually do not receive cardiac transplantation. So, the purpose of today's presentation is that whether CABG is an option for them. Now, CABG generally we have been avoiding in patients with LVEF less than 30% because the perioperative mortality was very high. But improved surgical techniques and better perioperative and postoperative management probably has made CABG as an option these days for patients even with severe LV systolic dysfunction. Of course, a surgeon will be quite happy to find if the patient still has angina. That will reassure him or her that CABG should probably succeed. Now, why CABG is an option versus cardiac transplant? Because in these kind of patients, it has been shown that both have same kind of perioperative mortality, and even the 5-year survival rate is also comparable between the two groups. Of course, the quality of life and functional capacity is better in the cardiac transplant arm. Now, an analysis of the data that we have showed that the mean EF in these kinds of patients receiving cardiac transplant was about 23%, and mean EF for patients receiving CABG was a little higher, 31%. So the kind of consensus was that probably even in this subset of patients, EF less than 30%, CABG is a better option for patients with so-called low risk with a little better EF, and cardiac transplant is a better option for patients with high risk and a low EF less than probably 25%. But then so who are these candidates who can receive CABG? Now, there have been several algorithms saying that we have to study viability, ischemia. Anyone with more than 7% of hibernating myocardium, more than 15% of ischemic myocardium would make them candidates for CABG. But then we have the protagonist of the STITCH trial, which in its 5-year and 10-year follow-up showed that even in patients with demonstrated viability, those patients went on to develop improved LV ejection fraction, but that did not translate into improved survival. So, does viability matter? Now, we have to remember two things. Of course, the supportive OMT has vastly improved subsequent to the publication of the STITCH trial. And there have been several other studies, like one by Cao et al., which showed that patients with low viability showed increased perioperative mortality, and patients with viability had improved 1 year, 2 year, and 3 year improved MACE-free survival. So I think the overall consensus these days that we should still look for viability and ischemia. Now, another point to be remembered in this context is that STITCH trial employed the SPECT and the dobutamine stress echo to look for viability. Now, these studies are good, but they have compared to the other imaging facilities available to us, they have suboptimal image resolution, plus they do not differentiate between hibernating and scarred myocardium. Now, probably with the availability of PET and MRI, we can have a better quantification because these SPECT and DAC was not being able to differentiate between hibernating and scarred myocardium. These PET and MRI put together can differentiate between the two, and they can actually quantify the amount of myocardial scar. So decision making should be absolutely good before we send the patients for CABG. Now, because majority of us here are cardiologists, so I mean the referral to PCI options in this setting, I think we should make some reference to that. We had the revived BCI S2 trial. We showed that patients with advanced LV systolic dysfunction less than 35% with multivessel disease, multivessel PCI versus optimal medical therapy, there was no improvement in all-cause mortality or improvement of LV systolic dysfunction. The mean follow-up was 3.4 years. Now, PCI, PCI, of course, produced a better quality of life and functional capacity, but there was no improvement in the hard endpoints. And of course, there was no difference with complete anatomical revascularization and even viability-guided revascularization again. So, and it did not reduce ventricular arrhythmia. So we are not really sure whether multivessel PCI would be applicable for these kinds of patients. So probably CABG again should be a number one option for these patients. So what should we conclude? We actually need risk scores and risk prediction tools dedicated for these patients of ischemic cardiomyopathy with advanced left ventricular systolic dysfunction, like the one we have by Yoon et al. For cardiac transplant, which is called the predictors, trees of predictors top. And now we need to devise risk scores like that. Of course, needless to say that any degree of RV systolic dysfunction in addition to the LV systolic dysfunction would preclude the role of CABG. Those are clear candidates for cardiac transplant. So with that, I will end my talk on this ischemic cardiomyopathy aspect. My the other topic is the current status of CTO PCI management. Current status, this was also thrashed out in details in the ACC 2025. Now, what is CTO? I need not relate. It is 100% occlusion of a coronary artery, which should be there for at least more than 3 months. Now, when we look at all the patients of CAD, 15 to 35% of patients are the data available that will have some CTO. Now, needless to say, CTO PCI is one of the most difficult subsets of complex PCI. Now, it used to be avoided by many angioplasters and used to be referred for CABG. But one data shows the Syntax trial that at least 30% of the patients who had CTO, these CTO vessels were not actually bypassed during surgery. Now the approach has changed with our improved understanding of the problem and with the improved availability of the various gadgets and improved techniques. So the success rate of opening up CTOs has vastly improved. But then whether we should open up all CTOs just because we can is something that I'm going to refer to later. First, let us have a look at what are the improvements that we have had at the understanding of the problem, and a few words about the gadgets and the techniques that we have. So we have like the JCTO score, which will tell us what is the probability of opening up a CTO. Now, whether the proximal cap is tapered or blunt, whether there is calcification, whether the occlusion length is less than or more than 20 millimeters, whether there is bending more than 45%, or there have been previous failures. Now, there are scores. 0 is easy. Anything between, anything less than 2 is intermediate. 2 is difficult, and more than equal to 3 is very difficult. So one should assess the CTO anatomy before accessing the problem. Now, the gadgets, there have been vast improvements in the number of wires that are available, the various kinds of it. There are microcatheters, and the supportive imaging has vastly improved. The CT coronary angiogram is a must before opening up a CTO. We would like to know not only the antegrade approach, but the retrograde approach to the CTO also. And in many cases, IVAS guided proximal cap rupture is also being tried. Now the techniques, the conventional antegrade now has been supplemented by the retrograde, and we have now the controlled antegrade and retrograde subintimal tracking, which is known as CART. There is reverse CART, there is directed reverse CART, there is extender reverse CART. So many standard techniques that have come to be acknowledged. Now the last topic, last aspect, should we open up all CTOs, because we now have the devices, the techniques to open them up. So we have the RCTs first, we have REVASC trial, we have Euro CTO, we have Decision CTO, we have Explore, we have Impactor, and we have the Comet trial. Now these, they were mainly short trials, follow-up, anything less than 12 months or so. Only Decision CTO had a follow-up of 4 years. And of these trials, Decision CTO and Explore included ACS patients as well. Now, overall summary of all the RCTs that we have, they improved quality of life. They even improved the LV ejection fraction, but there was no difference in MACE or no major hard endpoints, if we call the mortality, the MI, stroke, and revascularization, particularly in Decision CTO with 4-year follow-up, did not demonstrate an improvement in these parameters. Then we have the real-world data. Now, real-world data, there have been very large registries, Open CTO, Progress CTO, the UK registry, the IR CTO. Now, overall, the data from the real-world registries have been more favorable in favor of the PCI CTO. Now, one data I would refer to is from Park et al. From Korea, who studied more than 1,500 patients for a mean of 7.9 years. That is very important. And he stated that he demonstrated that the cardiac death was significantly less in the PCI CTO arm compared to the OMT arm, 10.4% versus 22.3%, a very significant p-value. So what he suggested that 3-year follow-up, we cannot demonstrate any significant improvement in cardiac mortality with the PCI CTO. But if we extend the follow-up as 3 to 10 years, then we will see some improvement in mortality. And this has been supported subsequently and very recently by Young et al., who showed that CTO PCI versus OMT, there was a decrease in all-cause mortality, MI, and a composite of both. And his mean follow-up was 5 years. So now there is evidence from mainly the real-world registries and some from RCTs that probably we can decrease CV mortality and CV events with CTO PCI. Whether we can improve overall survival is something that can be debated, but probably that too is likely. So now I will summarize by stating what are the current indications of CTO for my colleagues in the audience. So if the angina is refractory to maximum tolerated medical therapy. Number 2, if there is reduced LV ejection fraction with the evidence, demonstrated evidence of viability and ischemia. Now you can debate it again because Revive BC Revive trial was a negative trial. But still, if you are doing a CTO, you have to demonstrate viability and ischemia. And last of all, complete anatomic revascularization for multivessel PCI. First, open up the non-CTO vessels, then you can try opening up the CTO to make it a complete revascularization. Now, needless to say, this is one of the most complex PCIs, need to be done by very experienced and specially trained operators in a high-volume cath lab center. So that is my take on the current status of CTO, PCI in CTO. And with that, I would like to conclude. Thank you very much. I think that I have been able to stick to the time. Thank you very much, Dr. Jayashankar and Professor Manchanda.
Dr. Kumar, Sumitra Kumar, it was fantastic listening to you. You brought up all the important aspects of when to intervene, when to refer to surgery. Also nicely highlighted our limitations as far as PCI is concerned to offer other than a better quality of life. The hard endpoints are definitely most of the trials are showing that our medical management is perhaps as good as the stable PCI for stable ischemic heart disease. If there are questions, we can take 1 or 2. I think ECG, there has been no question in the chat box. so I don't think I'll disturb Dr. Kamal. But then, Dr. Ponde, if I may ask, do you have a very trained echo technician with you, or you do yourself to diagnose the HFpEF? Because you brought out some really beautiful images for us to see.
No, sir, we have got we are blessed because we got very brilliant technicians. There are a total of 11 in my hospital handling 4 machines. They have been trained by us only, but they have picked up and they are very passionate about what they do. So we are able to catch up these diagnoses far more effectively than probably other labs in the city. So we are thankful about that, sir.
Yeah, because the images were brilliant and you brought about very nice clinical cases and very good learning points as well.
Yes, sir.
Must commend you for the fantastic setup.
Thank you, sir.
I think I don't have anything much to add, sir. Professor Manchanda, I can hand over the proceeds to you if you have any more expert comments from your end, sir.
Thank you very much, Jaishankar. I think this was a very interesting session. It was very good, very educative. Unfortunately, the interaction was much less. We saw several ECGs, which we see every day, and these are difficult ones. And I think interpretation is very easy. I think ECG knowledge among the so-called new postgraduates is very limited. I wish there was more interaction, but doesn't matter. I think this will go to the postgraduates and they'll benefit a lot. Dr. Ponde really talked extremely well about an entity which is often missed, that is heart failure with preserved ejection fraction. And we know that the incidence was pretty low earlier, but now with the modern gadgets, as you said, it is possible to detect it, but high index of suspicion is needed. Unfortunately, although we diagnose it, but we still have very limited treatment for this. We have 4 pillars for reduced ejection fraction, but for this we have only actually 1 pillar, and I hope the treatment will improve. But this is a very common entity, as you said, as much as 50% of the patients have it, and as you said that there are several varieties of this, and I think one should be aware of it, because now the heart failure with the aging population, possibly it will outnumber the reduced ejection fraction also. And the third was extremely good talk. This is controversial subjects, when to intervene in ischemic cardiomyopathy, a very common condition, and there have been controversial sort of data earlier, as he said, STITCH trial and other things and all. And he said viability still seems to be appropriate because the STITCH trial did not use the latest viability parameters and all that thing. And he talked about, again, a controversial subject of total chronic occlusion, whether we should intervene or not. I think it was covered very well. And as he said that it is possible to open it, but I think one should be very guarded for this only if it's causing ischemia or causing LV dysfunction and the myocardium is viable. And if the angina is not controlled with the drugs, it should be done. Because there is a problem with 100% occlusion also, that you open it up very well. The patient had the small collaterals, did not have any LV dysfunction. Now, if this suddenly closes, the occlusion rate is also a little higher than the usual one, then the patient can get myocardial infarction also. So I think it has to be very cautiously done, but it can be done. And as he said, these conditions are there in which it could be done and all, and that needs technique and all that. So I think it was an extremely good session. I'd like to thank all the 3 speakers and Dr. Jaishankar. You conducted very well. Thank you very much. I think this is very educative. Thank you. Okay. I think we move on to the 3rd module, and again we have 3 interesting papers here, and this is going to be moderated by Dr. P.B. Jayagopal, who is very well known as one of the leading interventional cardiologists of the country and excellent teacher. He has a huge experience and a good researcher and all. So over to Dr. Jayagopal for the 3rd module.
Thank you, sir, for the kind introduction. I think we have really fantastic topics for discussion in this 3rd module. And without wasting much time, let me invite Dr. Rupali Khanna, who is a professor at Sanjay Gandhi Institute at Lucknow. I think it's a very important area. For example, when you have a patient coming with microvascular angina, or let's say the fairly normal coronaries, it really becomes a very difficult task to manage. So I think over to you, Dr. Rupali, to give your presentation.
Thank you, sir. And I think, as you mentioned, it's a very important topic and usually missed. So I will present through my slides if they can allow me to share my slides and are my slides visible?
Yeah.
Yes, ma'am.
Okay. So this study, which was just presented in ACC, was basically to see the primary and secondary outcomes in women's ischemia trial to reduce evident non-obstructive. It's basically a warrior trial. And we all know that management of these cases, it's a big challenge. So if we see the basic definition of INOCA, we all know that this is basically a patient who comes with exertional chest pain, but when we do their angiogram or the CT angio, they don't have an invasive disease. They stenosis, there is no significant stenosis, and it may be mostly a microvascular or vasospastic angina, which we term. And we can document ischemia in these cases either by treadmill, either by stress echo, or by a MIBI scan. So these patients usually are underdiagnosed or they are misdiagnosed in our OPDs, and they is not a benign entity which was used to be considered earlier. So this study was rationale was that these patients, especially women who undergo angiogram, about 50% they have a normal coronaries despite having the classical symptoms and despite having your CT angio to be normal. But these patients usually, when the few studies which have been done, they have been shown that they have a similar adverse outcomes, cardiovascular events outcome in the term of hospitalization of angina when they follow up for a period. So guidelines still they don't mention what to be the management of these cases because we don't know what exactly the pathophysiology in these. So there is a quite confusion how to manage these cases. But the small pilot studies they have shown that if we treat them with intensive medical therapy, which includes the statins and maximum tolerated AS or ARB, these patients usually benefit with the symptoms. So hypothesis of this trial was there was medical therapy. If we give an intensive medical therapy, we can delay the first occurrence of the MACE event in the form of all-cause death, MI, stroke, or hospitalization at the follow-up of 5 years. So it was basically a prospective multi-center randomized blind outcome trial. About 71 US medical centers were enrolled. They divided into two groups. One was intensive medical therapy, which included your high-intensity statins, ACE, ARB, and a low dose of aspirin in these cases. And a usual care was given as dictated by a treating physician, nothing, whatever the physician think that the patient to be needed for a symptom control were given in these cases. And they were followed up for 5 years. If we see the inclusion criteria, it was a very vague inclusion. They were all the clinically stable women who presented with angina, and they were either documented by CT angio that there is no obstructive lesion or by invasive coronary angio. No physiological assessment was done in these cases, and all the unstable patients, significant valvular heart disease, cardiomyopathy were excluded from this study. The outcome was seen at the 5 years, whichever the first event comes in the form of your death, MI, stroke, or hospitalization or worsening angina. And the secondary outcome was quality of life, time to return work, healthcare, angina, or cardiovascular death. So if we see the flowchart, how these patients were included, there were about 2,000 patients, 476 patients were randomized, out of which 1,239 were included in intensive medical therapy and 1,237 in under usual care of therapy. And these patients, if you see 50% about were there, and the 50% were diagnosed with CT angio and only 50% were invasive angiogram. And these were included for follow-up for 5 years and included in primary analysis. But if you see the baseline characteristic in these patients, the mean age was of 64 years. Diabetic were about 20%, which we usually see in all the patients in the post-menopausal were 82%. And if we see the anginal score, it was equivalent in both the cases, about 70. But the biggest thing, which was seen in this lipid, if we see in the intensive medical therapy group, there was 70% were prescribed statins as compared to 69.9. So no significant difference. And in ACE and ARB, which was considered to be a big major chunk in the patient of intensive medical therapy, was prescribed only in 53% of the patients as compared to 48% in the usual care. And the beta blocker also having the same tune in the range of your 40%. So when they followed up for 5 years, if they see the primary outcome, which included your cardiovascular death, stroke, hospitalization, they didn't find a significant difference in these patients, whether you give an intensive medical therapy or a usual care in these cases. And when they analyzed these cases, individual subgroups in these, they didn't find a significant difference. The event rate was equivalent in both the patient groups, and there was no significant difference. The secondary composite outcome, if we see, there was no significant difference in their death, MI, hospitalization, or in the form of anginal score, but definitely there was significant fall. If you see about 25% have an anginal hospitalization, whether you give them intensive medical therapy or a usual care therapy in these cases. And when they did the sub-analysis to see the subgroup, was there any difference among the group which was given in these patients? They didn't find any difference as compared to your age, whether they were diabetic or non-diabetic, or in terms of your hypertension, or in the case of postmenopausal stage, it was so totally equal in these both cases, whether you give IMT or usual care treatment in these cases. Was there any difference in the risk factors management when these patients were given IC and the IMT and UC? The systolic blood pressure, if we see, was equally in both the group. The only modest change which they found that they gave a high intensity therapy in the IMT group. So LDL was little lower as compared to your usual care group, which was about time average difference of 7.6 standard error of plus minus 1.5 standard error. So the summary of this trial was that if these patients of INOCA diagnosed either by coronary angiogram or a CT, when they followed up for 5 years, the intensive medical therapy, the MACE events was 16% as compared to the usual care, which was also 16%. So it didn't save any difference between whether we should give a IMT or your usual care in these patients. And the limitation with the study mentioned was that it was CT angio was contributed as only the enrollment part, and there was open label trial, so there may be some contamination in both the groups. And there was baseline, if you see the Seattle Angina Quotient score, there was less angina capacity improvement to angina related quality of life. But if you see my take, if you see the critical analysis, the major limitation of this trial was that a prescription of the statin, ACE or ARB, on which this basis the trial was started, it was not different. They were similar in between both the groups. So therefore, it is very difficult to draw any meaningful conclusion from this trial, because if both the trial therapy are given the same group. Second, this trial, if we see, was underpowered for the primary endpoint because there's only 1,200 patients in both the groups. So cardiovascular death measurement will be underpowered in these cases. The second most important is inclusion criteria with these patients. They included suspected INOCA. We all know that INOCA has different endotypes. They have a CMD or a vasospastic angina, which are different entities. And their management also changes when these patients are diagnosed by invasive physiological testing. So in this study, they didn't differentiate between CMD and vasospastic angina. And we all know the INOCA endotypes is predominantly is microvascular angina, but still they 17% contributes about vasospastic and 21% have the mixed picture. So these patients were not segregated in this trial. And if we see the ESC recent guidelines of CCS, they say it's a class 1B recommendation to do an invasive coronary function in these cases if we are suspecting INOCA. And these patients should be labeled whether it is your vasospastic or it should be your CMD in these cases. There was a study, which was a small study, which was core MICA trial, I think, which created this group discussion that why we should treated these patients. And this was the first study which defined that if I give a stratified medical therapy using invasive coronary function testing angina, there is significant improvement in their MACE events. So if you use management of INOCA, they have different lifestyle modification. And medical treatment, we know there is a difference between the CMD and vasospastic angina. Like if the patient is having vasospastic angina, you will not give beta blockers in these cases. And in the patients of vasospastic, you will prefer giving nitrates and CCBs. Whereas a CMD, you will prefer to give statins in these cases. And along with this, there have been ranolazine and trimetazidine have been shown that these patients may benefit with CMD. So this was the basic crux of the core MICA trial, which showed that whenever these patients were risk stratified into different endotypes and the treatment was given according to your different endotypes, whether you go for a CCB or a beta blocker or your ACE or ARB, they found that these patients have definitely an improvement in angina and quality of life no mortality benefit, but definitely there was significant improvement when these patients were risk stratified. So if you conclude this trial, the lessons learned is that this is the largest trial in INOCA field. Still, though, the core MICA trial was hardly 150 patients in both the groups, including, and this is about 1,200 patients in each group, about 2,000, more than 2,500 patients. So we know that these patients are usually understudied, but this is the first study which have done the maximum number of patients. But if we see the 25% at the end of 5 years, they have recurrent anginal hospitalization. That means there is a high burden. And this trial should not be considered that you have to discontinue the high intensity statin therapy or IMT in these patients, because this trial has several limitations, but it create awareness, and we need more future trials to focus on the stratified medical therapy based on underlying diagnosis rather than giving an umbrella treatment to everybody. Thank you.
Thank you, Dr. Grupali Khanna, for really going through this varied trial and also trying to dissect out what really went wrong with the trial and where and what we should really be looking at when a patient comes to this microvascular angina, or let's say the INOCA. Now, I think we will keep the discussion towards the end of the session. May I now invite Dr. Pankaj Jariwala, who's a very senior cardiologist at interventional cardiology at Yashoda Hospital. He is going to give us a lecture on the chronic coronary syndrome, the update that's happened. And over to you, Dr. Pankaj.
Hello.
Yeah, we can hear you.
Yeah, can I share my slides, please?
Please.
Yes, sir, please.
So these are my slides, and so this is a full screen mode. Okay. Good morning, everyone, and I thank Corona Remedies for organizing such a wonderful CME on Sunday morning. And I will be talking at the end with the chronic coronary disease management in 25. What is new in the guidelines? And so as we know that most of the time we come across acute coronary syndrome very commonly in our country. And these days we are having some patients of chronic coronary artery disease, and even the patient undergoes angioplasty or bypass surgery, and once their acute coronary syndrome part is stabilized, we still label them as a chronic coronary artery disease. And they continue to have events, and despite sometimes you have done a good angioplasty or bypass surgeries, still they remain symptomatic. So many of the patients, they come and say that still they're experiencing some shortness of breath and some kind of chest pain, and still we try to convince them because already the finance is one of the issue, and patient family also is not very much keen on getting complete again post procedures evaluation of the residual ischemia and other part. So there are many aspects of chronic coronary disease. So any patient who has undergone a treatment for acute coronary syndrome, later on it becomes a chronic coronary artery disease or chronic coronary artery syndrome. He remains to be in a chronic coronary artery disease arena. And anytime he can continue to have chronic coronary disease, or he can go back again and have another episode of acute coronary syndrome. So this waxing and waning between the acute and chronic coronary artery disease goes on, and once the patient, you label that it is a coronary artery disease, you have to have a proper care for the patient to prevent. The secondary prevention and tertiary prevention should be done at every level, so that they do not come again and again with recurrence of the acute coronary syndrome. So how to tackle acute chronic coronary artery disease without drugs? And very, very important is once they suffer acute coronary syndrome or chronic coronary syndrome, you have treated them, and now it is time to prevent. So very, very important to assess the risk factors, and lifestyle modification these days is very, very important. And usually what I do is, in my practice, I call them at the first follow-up, and I make all the family members, those who are near and dear and taking care of the patient, including patient in the center, and I try to explain them what are the factors which has led to the coronary artery disease. So we have a social support, and there is a lot of blame game, and family members, they do not agree. Sometimes there is a cordial or incordial relations, and disputes, psychosocial problems, economical problems. So all those things we need to tackle them by sitting and try to improvise the patient's further future course of action, so that the patient lives a better life without any symptoms. So that includes a lot of things, as I told you: social support, culture, and systemic racism, and economic stability, and healthcare literacy. Because the world is growing, we get a lot of international patients also these days, and we need to have a support system which are different from our country, so that also we need to identify, and we need to address them one by one. So environmental exposure, particularly education on symptom management, risk factors management, and trying to control their blood sugars, blood pressure, cholesterol goals. And many of my patient has these days, we are seeing occupational hazards. There are many working in the industries, they are coming, and auto drivers, particularly bus drivers, they are having a lot of air pollution as one of the main problems. So a couple of almost last 1 year, I have seen almost 15-20 auto drivers suffered with acute coronary syndrome, and they had very big ectatic coronary arteries with lot of large thrombus burden. So the air pollution is one of the very important factor to them. And those who are working in the coal field also, they get exposed to this bad air pollution, and they come to us. So extreme temperatures and wildfire smoke, these are also very important. So occupational hazards also, they are very common in the younger age, and those who are working in this environment. So that can lead to coronary artery disease. So patient education and finding out the etiology is very important. So the diet plays very important role. And I always tell my patient that almost your 60 to 70% of your coronary artery disease, or maybe more, is responsible because of your diet. So diet in Indian particularly subset, that too particularly in the any part of the India, if you say whether it is a North or South India, we have a lot of carbohydrate rich food, and saturated fats and fatty acids are very commonly consumed. And so lack of fruits and vegetables, lack of exercise, so all of them, they contribute. Trans fat is one of the very common. And these days social medias and all those things has put a lot of pressure, and people are watching those kind of food containing videos, and they are consuming all those kind of trans fat, and that is leading to coronary artery disease. So I think a proper education to the patient about the concept of the diet, what is there. Otherwise, they will go on asking each and every question what kind of food they have to consume. So that is very important. And weight management is very important for the patient. And these days we are having not only the non-pharmacological, but we have pharmacological. Lot of drugs are there, like semaglutide and tirzepatide, all those drugs which are aiming to reduce the weight. So patients are coming and asking, though, for even though costly molecules, they are coming and asking for those drugs, because they don't want to go for vigorous exercise and walking and other things to reduce their weight. So you need to encourage them rather than having a shortcuts. Better to they go for weight reduction using some kind of exercise related patterns in their lifestyle, so that they can reduce that well, sustain it. Pharmacological, of course, they are very good drugs. They have shown the mortality and morbidity reductions, but they are costly, and patient may not be able to sustain them for a very long period of time. So what is the cheapest is the best, and they should try to use this weight reduction depending upon their requirement. So psychological assessment is very important these days. And whenever patient comes with coronary artery disease, they have a lot of depression, psychological issues, and they go into depression thinking, and they have a lot of patterns, mental stress and trauma. They are already having some kind of mental and stress trauma before coming to us. And with that, they suffer a coronary artery disease that will add to their agony further, and which will go into vicious cycle, and from the patient may not come out. And these psychological issues are also very important, because if they may not continue the medications, and the chances of non-compliance of the drugs also is very high when somebody has a psychological patterns which has been described. So, of course, pharmacological approach to the chronic coronary artery disease, we have been taught from the days of our cardiology training, and the basic drugs which we used to use, they are not recommended, like omega-3 fatty acids, vitamins, multivitamins and all. And what is more important is LDL cholesterol reduction. And the aim is less than 55 as per the European Society of Cardiology guidelines. And our LI guidelines say that those who are high risk should be less than 40, and those extreme high risk category patients should be less than 30. So that is what the guidelines for Indian subset of patient, we have different guidelines. But if you follow the Western guidelines, everyone says that those who have already suffered coronary artery disease should be lower cholesterol is always better. So the SELECT trial, which was again a semaglutide, weekly semaglutide 2.5 milligram, is not available in our country. And but still we are using oral semaglutide, and thinking that both are same molecule. And SGLT2 inhibitors versus GLP-1 receptor agonist, when they were given in heart failure, they have found that there is a better reduction and recurrence of the heart failure is prevented. Beta blockers are very, very important drugs. We have to incorporate in our prescription to all the patient, and antiplatelet therapy should be given as per the guidelines. So if patient has undergone angioplasty, then as per the guidelines for 1 year, followed by one single dual antiplatelet. If patient has multiple vascular territories, try to add a low dose of rivaroxaban 2.5 milligrams throughout their life, with a high dose of statin and beta blockers. So these are very important. So these days I'm using a lot of bisoprolol. It is a wonderful molecule, and once daily dose gives a good compliance to the patient. And this irrespective of the ejection fraction, you can use bisoprolol very well. Even the patient is hypertensive, it helps to control the blood pressure along with the angina episodes and heart failure. So one drug for all the problems can be given using bisoprolol. And social population, females, postmenopausal females, pregnancy, all of them, they need a restratification. Of course, I will not go into the details because that is a totally a different area. And angina, whenever you have to use nitrates, calcium channel blockers, beta blockers, and some kind of drugs like trimethazidine, which are vasodilators and non-vasodilators, basically what we call it as a metabolic modifiers. So always try to combine these two drugs, which are vasodilators like nitrates and metabolic modifiers like trimethazidine, so that they act as a synergistically, and it gives a good effect to the patient. And those ranolazine is particularly used in the patient, those who are refractory to angina. But these days ranolazine use in my practice has come down significantly, because most of the patient undergo some kind of revascularization. Adding ivabradine is very important if the patient heart rate is on higher side. Try to keep the heart rate below 70, so that their angina goes down. Despite of the beta blockers, if you are unable to increase the dose of beta blocker, or if there is a contraindication. So top 5 key takeaways is SGLT2 inhibitors and GLP-1 receptor agonists are recommended in patients of chronic disease, because they, with or without diabetes, and they have shown benefits in this group of patient. Shorter duration of dual antiplatelet like 1 year, followed by a single antiplatelet using clopidogrel with or without rivaroxaban 2.5 milligrams, particularly those who has a higher risk of vascular events. Statins are very, very important drugs, and it has to be given in aggressively to reduce their LDL cholesterol to the less than 50 level, particularly to prevent the recurrence of coronary artery disease. And these patients should be given a good newer beta blockers like bisoprolol, so that which has less side effects and more beta selectivity, and these drugs acts in a once a day manner, which is very good. So you can use other drugs like bempedoic acid and ezetimibe also as a statin if he is unable to control the LDL cholesterol, or newer drugs like inclisiran or evolocumab also can be used depending upon the pockets of the patient to keep the LDL of the patient on the lower side. So when to revascularize the patient, class 1 guidelines, despite of GDMT, still patient is having anginal episodes, and you do a stress test and you show that there is a large amount of ischemia is there, like more than 10 to 15% of the myocardium is at jeopardy, and the patients are still symptomatic, I think then you should go for ischemia trial where the stable coronary artery disease patient, moderate ischemia, randomized to early invasive versus they shown that. But after 4 years follow-up, if you see invasive management, they did not do well versus they had little benefit as compared to the conservative management. So there was a lot of discussion happened those days when these trials were published, including Arbiter trial, functional significant CAD, and all anti-anginal medicine discontinued, randomized to placebo versus PCI, and no significant differences were seen in the clinical events. So this was again Arbiter trial were there. So at present, FAME-3 trial also shown ACS versus CCD, 3-year rate of death, stroke, myocardial infarction, and PCI. In fact, if you see the PCI without DM and CABG without DM, they did better as compared to PCI with DM. So diabetes is one of the strong risk factors which needs to be controlled very well. So CCD, particularly chronic coronary disease, only patient should be treated when patient has significant angina, despite you have a maximum tolerated doses of anti-anginal drugs, and you have done a good amount of stress test, and you have documented that there is a large ischemia is there, like more than 10 to 15% of the, particularly the LAD territory, if it is there, then it need to revascularize. Otherwise, these patients, they do very well with the lifestyle modification and risk stratification for this patient and controlling their proper diabetes. And always you need to have a physiological guidance for this patient using FFR or some kind of OCT or angio FFR. So that gives a better, rather than opening all the arteries, only the ischemia producing areas, if you tackle them, they do very well along with the medical management. Thank you very much.
Thank you, Dr. Pankaj, for taking us through the newer information in the American guidelines 2025. Now, you've really taken us through all the non-pharmacological approach, the drug therapy, and also the most important question to be answered: when do you really intervene in this patient and then do a proper revascularization? I think we'll keep the discussion towards the end. May I now invite Dr. Purnanand, who is a very senior cardiologist at Vijayawada. So he's going to deliver the top takeaways from the 2025 ACC in terms of all what has really been discussed there. I mean, taking us through most of the newer information from the meeting. Over to you, Dr. Purnanand.
Morning, Dr. Jayagopal and dear friends and colleagues, senior colleagues. So I have been given the topic of, can you see my slides? Jayagopal, can you see my slides?
Yeah, I think it's full screen. Yeah, it's fine now. I think go to the full screen mode, please.
Yeah. So I have been given the task of discussing the intravenous iron in patients with systolic heart failure and iron deficiency to improve morbidity and mortality in view of the FAIR HF2 trial, which has been presented in ACC 2025. Basically, the background of the trial is the uncertainty which remains about the efficacy of intravenous iron therapy in patients with heart failure and iron deficiency. Both the two things are very controversial. One thing is how to define what is the iron deficiency, which in heart failure patients we don't have any clarity. We have taken the definition from the nephrologist. Based upon their definition, we are thinking that this patient is iron deficient. And the heart failure dynamics and the CKD dynamics are extremely difficult, and the chances of patient having iron deficiency in CKD are high, whereas heart failure patients are relatively low. But still, heart failure patients do have some deficiency of iron. And how does intravenous iron therapy, which is being advocated, will improve the dynamics, patient dynamics, quality of life, quantity of life, and recurrent hospitalizations. So there have been few number of trials which have been launched before COVID and were not able to complete or partially complete or were not able to give us adequate information regarding how to go about intravenous iron therapy in patients with heart failure. Here, this trial, FAIR HF2, was objected with an objective of to assess the efficacy and safety of ferric carboxymaltose in patients with heart failure and iron deficiency. We have been using this FCM with the data which is available. Especially most of the data has come from Stephen Anker group, where they have strongly advocated to use iron therapy, and they have shown significant benefits in before trials like Affirm HF, Confirm HF, Effect HF, such kind of trials. But the number of patients involved in those trials were a bit limited, so that we did not have much confidence in using in every patient with heart failure. Here, the eligible patients are with chronic heart failure with reduced ejection fraction of at least 3 months, ejection fraction less than 45%. So only patients with heart failure with reduced ejection fraction were used. And the evidence of iron deficiency was serum ferritin level less than 100 nanograms per ml, or if transferrin saturation was 20%, or if the serum ferritin is between 100 and 299, the only transferrin saturation of less than 20% was taken as inclusion criteria. At the time of screening, eligible patients were considered were restabilized and eligible for hospital discharge within 24 hours, acute heart failure deterioration patients but stabilized, and stable ambulatory patients with heart failure, and stable ambulatory patients without symptoms also but with elevated natriuretic peptide levels. So basically you are looking at patients who are stable medically and symptomatically when the patients were included into the trial. So this is patients who are almost chronic heart failure with no acute decompensation or no acute symptoms. So this is a stable heart failure patient. Patients who are excluded were when there is known hypersensitivity to any component of FCM, ferritin concentration more than 300 micrograms, or hemoglobin concentration more than 9.5. There is no anemia, and history of treatment with erythropoietin stimulating agent, which can give controversial findings or different findings when they are used with FCM, and received any intravenous iron or blood transfusion within 6 weeks. Both these things will interfere with the results, so those were excluded. So the recruitment and randomization and follow-up was 1,824 patients of heart failure were assessed for eligibility. 719 were excluded because they didn't get into the inclusion criteria, and all others, some because of their death or some circumstances seem to be harmful or consent and unable to get the consent, they were excluded. And 1105 patients were enrolled and randomized, out of which 558 were received ferric carboxymaltose and 547 received placebo. But you see that this is because during the COVID time, so there are around 369 only completed the randomized treatment, 189 discontinued treatment. This is a very high discontinuation rate in this trial. 128 for personal reason, especially for the COVID, and others for adverse events or health-related reason. Even in the placebo group, only 341 received and 206 discontinued treatment. This is basically because the inability of these patients to come to regular visits during the COVID time. Because this trial has been started around 2017 and completed by 2023, and so most of the COVID period was during this trial period. So in this, 558 are included for primary analysis and 554 are included for safety analysis. The same with 547 and 545 were included for primary and safety analysis. You see that most of the patient characteristics at baseline were equal. Most of the patients were at the age of 70. Females were 35%, in 30% in placebo group. Most of the patients had diabetes, hypertension, myocardial infarction, percutaneous interventions, CABGs, and all these things. Basically, end-stage heart failure because of both ischemic and non-ischemic reasons. And many of the patients were in class 2 and class 3, that is a stable heart failure. And you can see the iron indices. Many of the patients had reasonably high hemoglobin values. They are not anemic, but many of the patients had less than ferritin values, which the baseline values or the mean values were around 70, 72, and the transferrin saturation was very less than 20% in most of the patients, indicating that the trial was basically for chronic heart failure patients with iron deficiency, not anemia as such. So it is a multi-center randomized 1:1 double-blind placebo-controlled trial started in 2017, and the 2024 it was terminated, and in 2020 December 24 the results were published. So after screening these patients, number of patients, the follow-up was 21.3 months, 8 to 30 months. And patients, we are looked for primary endpoints like CV death, heart failure hospitalization, time to first event, heart failure, recurrent heart failure events, CV death, and heart failure hospitalizations in subgroup of patients with TSAT less than 20. Because this is one thing which is they were specifically looking. TSAT less than 20 is the indicator for iron deficiency in this such group of patients. And secondary endpoints are change in NYHA class and 6 minutes walk test or baseline from the baseline 12 months. So Stephen Anker was the main person, and most of the trials were conducted in the European centers, 6 European centers across the Europe, and most of them are white population. So we have to interpret with caution and also think that our iron patients are more iron deficient, maybe more iron deficient, especially in heart failure. So the cumulative primary endpoints, first to see time to first hospitalization to heart failure. So there was some change between the placebo and ferric carboxy maltose group, but over a period of time, they both the curves almost met with each other, and after 36 months, so it was not statistically significant. So with the same recurrent hospitalizations also, so they diverged at a point of 12 months to 30 months, but they remained diverged for 36 months, but still the values are not statistically significant. And time to first hospitalization and heart failure in TSAT, that is less than 20%, there also the curves tend to diverge a bit and converge after 3 years. So indicating that these 3 values which are looked for primary endpoints were not statistically significant. The one thing which was very surprising was even the distance on 6-minute walk test was also not significantly improved, or there is very minimal improvement even after very high iron replacement therapy. And even the NYHA classification was also not significantly improved, indicating that both the patients didn't experience any significant treatment benefit, and also the 6-minute walk test, which is a useful parameter, clinical assessment parameter for many of the patients with heart failure, also did not significantly make any change. So, but the relative risk was reduced by 21%, that is time for CV death or HF, and the recurrent hospitalizations were reduced by 20%, and especially TSAT 20 less than 20% also there was a relative risk reduction of 21%. But all these things did not receive statistical significance because that the number of patients of discontinuation were very high, follow-up was relatively shorter, and even though there is a recommendation of IV therapy in heart failure patients, there was a propensity for discontinuation. This made probably patients to be hospitalized for a 1 hour period or 2 hour period, and not an outpatient treatment, need of cannula insertion, the risk of side effects, and all these things made the heart failure patients who are already sick with so many medications do not want to take another chance for a treatment which is marginally beneficial. So, but the trial was planned to see that the observed differences between treatment groups were to be different from previous trials, but they were ultimately, when they came to know that all the patient characteristics were similar. So heart failure, FAIR HF2 concluded that when comparison to the other trials like CONFIRM, AFFIRM, Ironman, and Heart FID trials, the results of FAIR HF2 trials in terms of impact of M&M events, morbidity and mortality events, are highly consistent with those of AFFIRM HF and Ironman. but do not reach statistical significance within the trial, because the trial design and also the time of trial did not make much benefit, and the discontinuation rates make things worse. And FAIR HF2 trial suggests that both the classical iron deficiency definition using ferritin and percentage TSAT or a simplified one using only TSAT are useful. So this less than TSAT to 20% is very consistent with the bone marrow iron staining. So this is one has to be used more consistently to see the benefits in patients who have iron deficiency in heart failure. And FAIR HF2 confirms the benefit of intravenous iron therapy on quality of life and patient self-reported health status. So though you have to take this suggestion with a pinch of salt, but basically the Stephen Anker group were strong in advocating intravenous iron therapy over a period of long time. And when you see the Ironman trial, which has been one of the important trials before this FAIR HF2, their take-home message was, in clinical practice, anemia and TSAT less than 20%, which are strongly related, identify patients with heart failure and most likely to benefit from intravenous iron therapy, whereas the value of measuring serum ferritin is uncertain. So Ironman also didn't show significant benefits, basically statistically significant benefits, but it has given us a message that TSAT less than 20% is more reliable indicator for iron deficiency than the serum ferritin levels. So out of the 10 trials which have been RCTs, the message is the relative risk is less than 0.75%, but you are not getting a clear picture regarding how the iron therapy will improve significantly the morbidity and mortality. When you compare the same data with heart FID trial, where the iron deficiency was corrected with the ferric FCM, there was no significant morbidity or mortality benefit. So basically, TSAT more than 20% is an indicator that these patients have less mortality when compared to TSAT less than 20%. So this is out of all the three indicators: TSAT less than 20%, serum iron, and ferritin. Ferritin is most non-specific. Don't use it for administering iron therapy. Use TSAT less than 20%, then you will be more rewarded with the therapy. So because ferritin increased because of inflammation, which is present in most patients of heart failure, using TSAT less than 20% and especially will be more indicating the poor prognosis, and probably these patients will benefit more with intravenous FCM than patients who have only low serum ferritin. Thanks for your attention. And
thank you, Dr. Purnanand. I mean, all of us agree that we had a really good session. 3 topics. The first, of course, by Dr. Rupali Khanna was mostly on INOCA, I think, and the second, of course, on chronic coronary syndrome. Finally, something in heart failure. So to start with you, Dr. Rupali Khanna, I think you really dissected out the trial very well. In fact, when you look at this INOCA, it's actually a very heterogeneous group. You really brought out that point where some of them have coronary microvascular dysfunction and some others vasospasm. So I think in the current era, going by the trial design, it's probably not the right way to look at things, because vasospasm is an integral part of and then if you miss that and if you're not on the right medications, the overall outcome would be different. That I think you brought it out very well. The only question I just wanted to ask you is, actually, there's a recent this thing by the Sky, where they're divided into 3 major groups. One is this microvascular dysfunction. Second is, of course, the vasospasm. And the third is the muscle bridge. In fact, that's been now looked into as another major entity. So combination of, let's say, the muscle bridge with the spasm or muscle bridge with the endothelial dysfunction. So again, the question comes whether the use of beta blockers. There was a time when we thought that, you use beta blocker inappropriately in a patient with vasospasm, it has the opposite effect. But then if it's a myocardial bridge, we know it works well. The question is, what about the newer beta blockers, Nebivolol? It's useful in terms of endothelial dysfunction as well. Does it make a difference? That's the first question to you. Secondly, one other area which has been missed out is probably the inflammatory markers. Nothing has been said about that in this particular study. What's your comment on that?
I agree, sir. The beta blockers are the most, I would say, most used and most underused drugs also in these cases, because definitely there has been a theory which since long ages that vasospasm, if it's there, then beta blockers should be avoided in these cases because it might deteriorate the symptoms, and CCBs and nitrates would be preferred. But definitely myocardial bridges cases, and I think that can be anatomically documented if you're going for a coronary angiogram in these cases, and a CT can also clearly show these. If we see in real world scenario also, sir, it's in our cath lab, it's very difficult to differentiate between CMD and vasospasm because we don't have CMR, we don't have IMRs, we don't have CFRs, we don't do acetylcholine test very frequently in these cases. So if we see these cases, what we in clinical practice we should follow, we usually prescribe these drugs, and we found that these symptoms are getting deteriorated. Then you take out the beta blocker in these cases when they present with INOCAS. And I agree that newer newer mechanism of these beta blockers can be definitely used in nebivolol because they have been shown to less vasospasm in these cases and endothelial dysfunction which has been decreased. So if we ask a real world scenario, we really don't know at what is the mechanism leading to INOCA, and these patients should be tried with your. If you on angio, we are getting not a single CAD, not a mild CAD also, then we usually go for a CCBs. And in these cases, if we find a mild CAD, then we start all the treatment of ischemic heart disease in this. The second topic question was your
inflammatory
related
markers,
to
CRP.
Yes, sir,
CRP.
Yes, sir. I think that's a very good point, because why this INOCA is more common in females, or there have been a various study which has done HSCRP, which have seen that rheumatoid arthritis, any inflammatory disorders which have been there, they have these associated INOCA in these patients. And documenting HSCRP or a rheumatoid arthritis factor also in these cases, and a patient is complaining of chest pain, then these patients should be labeled as at your INOCA patients, because this is an inflammatory disease. Whether to start, because these are RA, SLEs, there have been several subsets, because RA have already shown that they have increased risk of developing your anginal symptoms despite having a normal coronaries. So inflammatory markers definitely play a major role in these cases. And if you see the study was a very vague study. They didn't evaluate any inflammatory marker. They didn't evaluate, because it was only on the clinical symptoms which they assess, whether it is a cardiac or a non-cardiac chest pain. They didn't differentiate that also. And sometimes going for just for CT and not doing any angiogram, because sometimes you get a STIMI2 flow, and that also, sometimes tells you on angiogram there may be some coronary microvascular dysfunctions. So that's why I think the study didn't address these INOCA patients appropriately.
I think it's fairly clear there are a lot of flaws in the study. In fact, some of these patients, when you take them to the lab, you find they're slow flow, for example, ectatic coronaries, and then slow flow. In fact, if you don't do anything to address that, I think the whole purpose is defeated. So I think the lack of a coronary angiogram and then all this provocative testing, which is all left out, is probably the biggest, drawback of this particular study. Now, I think there are a lot of questions in the chat, but I think it's interesting just to see this publication came a couple of days ago. The Sky, they have now beautifully put it into these patterns, and nebivolol, there's been studies quoted where it's found to be superior to other beta blockers. And in fact, some of the recommendation today is you add a beta blocker along with a calcium channel blocker, just like what we used to do decades ago. And this is supposed to be much better if you have really documented in INOCA. So I think this is interesting, coming back to the age-old medication, which would probably address these issues. I think there are a lot of questions in the chat box. Dr. Vishal is asking, how important do you think advanced imaging or biomarker research? In fact, that is what we were talking about. The biomarker research is about the inflammatory markers particularly. And how long, that is another question. Do you think aggressive lipid lowering should remain a priority for Indian women? So this is what the study was. Dr. Kana, your opinion?
So I think this INOCA subset, if we see the lipid lowering, because these, if you see the various earlier studies also, they have this traditional risk factors. It's not like they don't have the traditional risk factors. Still, what we see, if we see the oral WISE study also, they mentioned that the 20% were diabetic in these cases, which we usually found in all the other studies also. So definitely, if they have a traditional risk factors, the lipid lowering should be definitely started as recommended in the patient as we compared in CADs. And if on angiogram we find mild disease or some irregularities, and there is some STIMI to slow flow, which we usually see in our patients, then I think statins should be given in these cases at a high intensity statin. But if it is clearly a very young female, and in that cases, it's still a little query, which we don't know whether we should start or not. But majority subset, if we see the different endotypes also, 51% contributes CMD and 70% contributes or overlapping picture. That means 75% will have some CMD underlying with traditional risk factors. So statins should be given in these cases, because in our lab, we don't have CMR, we don't have IFR, CFRs and IMRs. We don't do acetylcholine tests. So this is basically clinically, which we have to interpret from our study, from the different studies, at how we can use in our patient subset in our cases, sir.
Maybe as a practical thing, the frame count, I was particularly mentioning
Maybe
about
flow.
the
Yes, sir.
slow flow. I think, but
Yes,
then
sir.
the question is, when you find a slow flow, ectatic coronaries, are you tempted to use an antiplatelet or an anticoagulant in that context? I'm just putting a hypothesis. There is no data on this.
No data, sir. What we do is, like, if a very ectatic artery and patient comes with acute coronary syndrome, like unstable
Of course.
angina or a
I'm talking about
non-ST, we usually give these cases anticoagulant in these cases. But if it's a stable patient of a proximal mild ectasia, or is there not a big aneurysmal, then not anticoagulant. Yeah, definitely antiplatelet we usually give in these patients, sir.
Thank you. Thank you. I think you really covered the topic very well and really brought in a lot of discussion. Over to Dr. Pankaj. I think the same question here. Chronic coronary syndrome, I think in the European guidelines, it's very clear that you look into the inflammatory markers. HSCRP has become an integral part of it's a diagnostic tool. Dr. Pankaj, are you there? Maybe Dr. Rupali, you can address this. I think it's become a guideline today as a diagnostic tool, HSCRP there. But then all the trials have shown, in fact, the post-MI, none of the anti-inflammatory agents do the job. So
I think this all started with Jupiter trial. This HSCRP came into the picture, and I think Jupiter trial have really shown that the primary prevention trial with these, and definitely these patients when post-MI. Sir, actually, what I feel, anti-inflammatory, the only drug which we have is a colchicine at present. And
even
if we
that's
see the
post-MI
colchicine, but the data is very controversial.
Controversial. Now it's going off. Yes.
Yes, sir.
And
We don't have a very clear-cut data. It's a very controversial data. But if we have a recurrent event with raised inflammatory markers, then I think this anti-inflammatory drugs may be a small subset of patients may hold. But a routine checkup, a routine follow-up in a primary prevention, a secondary HSCRP should be done, and statin drugs should be started in these cases rather than anti-inflammatory, sir.
Yeah, I think it's interesting to note about the social. Dr. Purnanand, you can also possibly chip in. See the social determinants of health. In fact, what is interesting to learn today, in the acute heart failure or the chronic heart failure scenario, is loneliness. It's been thought to be, at least the Western world, to provoke all kinds of events. So I think it's something which probably in a developing country like India also, it's becoming more and more relevant. So I think that's something which is, and again, we cannot forget about the role of infections. We saw during COVID times, the patients with chronic coronary syndrome suddenly getting an acute event precipitated by an infection. So I think this is something which we are really not, even the guidelines have not been very clear on this. Of course, in heart failure, you talk about vaccination. Yeah. Kana?
So one thing, like in loneliness, you said, like in our patients, when we see the stress is coming as a very big factor. And in our history, we always ask, do you work in a metro city living alone? Or like we have a small subset of patients going to Middle East, they're living alone. And if we do their angiogram, they're getting a very bad diffuse diseases in these cases. So this parameter of loneliness, staying away further from the family because of your work, I think they are having their own good diet patterns also. But despite that, they're having I think this is a very big factor which need to be evaluated for developing CAD.
Maybe the stress factor provokes a lot of sympathetic overactivity, and God knows. I think this is probably one hypothesis that people can work on. So I think it's interesting that beta blockers, which is often talked about, the post-MI has been one of the drugs which has been always used. No doubt when you have a patient with a low EF. But then what happens if you have the American guidelines say more than 50%? No need. But of course, in the present era of when you take up a patient post-myocardial infarction, open up the arteries, and you have a near normal ejection fraction, do you really need a beta blocker? And question is, and when they get into chronic phase, how justified? In fact, today the recommendation is not to use a beta blocker if you have a normal LV and if you're revascularized.
I think the recent data.
I'm sorry.
I'm sorry.
Yeah, no problem. So the controversy is there for the patients who are between the 50 to 60 group. So anyway, less than 45, you have a lot of evidence
No,
saying
LV dysfunction is different. I'm talking about a normal EF.
that's what, sir. So
Yeah.
the only the people who are between the 45 to 60 group, where the 15% margin, where the patients, the beta blocker do not have evidence. Less than 45, LV dysfunction, irrespective of is it ischemic or non-ischemic, your beta blockers have a role.
That's okay. We are not talking about LV
Then
dysfunction.
yes, sir. And
Professor
60%.
Manchanda, sir, I think, sir, what do you think?
Yeah, I think before the revascularization came, these beta blockers were indicated. And after even thrombolytic therapy, some studies showed they are not used. And after angioplasty or after bypass surgery, if the ejection fraction is more than 50, there's no need, unless there is some other indication. So there's no need. I think the data is now coming. But if a patient cannot be revascularized, I think beta blockers are still indicated because the old studies have very clearly shown. This is before angioplasty. So I'm talking of the past. Several studies showed that beta blockers are useful in patients of myocardial infarction if they cannot be revascularized and all. Maybe they had some amount of LV dysfunction, which was really not picked up and all that. Therefore, they did only ejection fraction. They didn't do any of these newer parameters of LV dysfunction. But I think if a patient is not revascularized, possibly beta blockers should be given. But if he has an angioplasty or a revascularized, then there's no need if ejection fraction more than 50.
Actually, two things are very surprising for me from these American guidelines. One is the ezetimibe has now become a cornerstone of therapy in the acute coronary syndrome. You add ezetimibe along with the high-dose statins. That's not mentioned. In fact, you keep talking about aggressive lipid lowering. Nothing is mentioned about ezetimibe. And secondly, ivermectin is a class 3 harm in a chronic coronary syndrome. I cannot take it because there are a lot of patients, despite beta blockers, you're not able to control the rate and they're symptomatic. And what about patients who have a bad asthma or a lung chronic? This is a wonderful drug in that context.
Yeah, I agree with you. The reduction of heart rate is important for all patients, and if they cannot be controlled if it's more than 70, you should give ivermectin. But if a patient absolute contraindication for beta blockers, ivermectin can be given because if you say physiologically reduction of heart rate will improve the coronary physiology, so coronary blood flow, etc. So I think this is clear about it. The guidelines really are not sometimes very clear about it because one study or the other which comes, just like you heard these two studies earlier, iron was being given earlier, but now it's come down. And similarly, for microvascular angina, we had really nothing at all. And we used to say that you can start giving the usual therapy, but you see the beautiful study quoted by Dr. Opali, there is possibly no benefit at all. But of course, this was both these studies had a lot of limitations. I think which were presented. The iron study, there's so much of dropout was there. I don't think you can really draw any conclusion. Similarly, as Rupali said, unless the endotypes are really found out, you cannot really say that. And one drug which we have found very useful, it has been used in some small number of patients, is this trimetazidine, which has been some small studies are there. I have also done some studies that with normal coronaries, if you give with angina, this is beneficial because it acts at the metabolic level. Whatever is the cause of angina or cause of ischemia, this takes care of that. So I think that more studies are possibly needed. Trimetazidine. I agree with Rupali that it's not possible to really do these studies of endotypes. They're difficult. That's why this was a practical study to see that. But again, this was not a very good study because the endotypes were not really there. They should have separated.
It really works well. Trimetazidine in some patients. Coming
Yeah,
back,
it does.
Yeah, and sir, coming back to the ischemia trial, I think we all talk about the flaws, a lot of criticisms. Finally, there is a lot of crossover. In fact, one of the major things that in your practice, if you come across a proximal lady, I think women, I don't think anybody would take a chance in putting this patient on a, and if it's easily revascularizable, I think that's a question to be answered.
No, I think this is a good trial, but this is a very select number of patients. These are patients who had no other problem, like ejection fraction was normal. They did not have any significant comorbidities. They were simple cases of angina and they had moderate ischemia. And that's all they had. LV dysfunction was not there. They did not have any other problem and all that thing. So I think in select number of patients, medical therapy there, but majority will need it. Even if the crossover is there, it doesn't really matter, but at least you save one angioplasty. There is a re-angioplasty also in several cases of PTCA also. You know that very well. Because if they don't follow the lifestyles properly and they don't follow the drugs, we know that majority of the patients don't follow lifestyle. Majority of the patients don't even take the drugs properly, especially in India. The discontinuation rate is very, very high. So I'm not surprised that even if there's a crossover, I think initially you prevent one angioplasty, but after angioplasty, you can't say that second won't be needed. Yeah, so I think whatever it is, for limited number of patients which are there in ischemia trial, in the other trials also, I think this is useful and all. And even if you can postpone angioplasty for several years, it's still worth it. But I think what I have seen is that if the patients follow the lifestyle properly, including a lot of has been said about psychosocial factor. I agree. This is by my research, and we have done several studies, yoga for reversal of heart disease, etc. And several studies are available now. That even if you see inter-heart study, Salim Yusuf study, which was there in more than 50 countries, these psychosocial factors were as important as smoking was. So the odds ratio was 2.52. And what he meant by, as you said, there are so many factors which cause coronary arteries because of stress. One is the sympathetic dominance. The other side is the neurohormonal system. Is stimulated, cortisol, etc., several enzymes, etc., and they interact. And inflammatory markers are also increased by stress and so on. And there's a study done from GB Pant Hospital. These are patients less than 30 years, no risk factor, but they have myocardial infarction. So they were studied. Why did they get? The only factor which came was stress. And then they found out that even their telomere length, although they were 26 years, but their vascular age was maybe 70 years or so. Telomere length they showed was also decreased in these cases. So if you have severe stress, you age very quickly, maybe your vascular things also. And these are no other risk factors. A beautiful study which was presented in somewhere, and it was shown that telomere length also can be affected, and yoga can prolong the telomere length. There are 2 or 3 studies available for that. So I think the stress factor has to be emphasized quite a lot, and I have been studying that for the last 30 years. And if you see as I said, intra-heart study, psychosocial factor is very, very important.
Dr. Purnanand, I think you really analyzed this Fairheart trial very well. The question is, I think the dosage you find that was given was 500 milligram every 4 months. If you look into the study design, there are questions asked by some of the patients. Correct their ferritin. Down the line, they come back to you, and if you recheck ferritin, if it's normal and the TSAT is more than 20, do you think the question asked is, do we need to continue? We know that IV works better than the oral because of the heptizidine and things like that. But then beyond a stage when the transferrin level becomes normal and your ferritin level is also normal, can you maintain them on an oral? These are the questions asked by the patients. What's your comment on that?
Yes, sir. There are some 2 trials which are going with oral iron also, which can improve the TSAT and also serum ferritin levels. And here also, when the serum ferritin goes more than 300, and the chances of overloading the patient with iron is a risk in heart failure patients, because excessive iron in the myocardium can cause myocardial damage and also probably oxidative stress on the myocardial cells. So here, if your TSAT and serum ferritin are corrected more than 300 and TSAT improves more than 20%, there is a less evidence for us to push the patients on a very high doses of intravenous iron. And if patients are still anemic, if they by any chance, if the serum ferritin and TSAT are more, then probably oral iron therapy is one of the microsomal iron therapy is one of the advocated in such patients. So to maintain a state of adequate iron state, because iron overloading is totally no in these patients of heart failure. So oral iron therapy can be given to our patients who are willing to take it, because we have to inform the patient that keeping your ferritin levels and TSAT more than 20% may help you to improve the quality of life, but may not improve the quantity of life or the current hospitalization. Probably they have a benefit, but if you use it, this is an additional medication which can improve better than carnitine or some other things which can have no significant benefit in these kind of patients.
All of you would agree that we had a fantastic session by all the 3 talks were superb. Dr. Rupali Khanna talked about INOCA, Dr. Pankaj on the chronic syndrome, about the new in the guideline, and finally on the heart failure. I really learned quite a lot, and I'm really thankful to the Corona people for having invited me. And finally, over to Professor Manchanda for his closing remarks. Thank you.
Thank you very much. I agree with you that this was the most fantastic session. We had the maximum discussion. And thanks to all the three speakers, I think all these three speakers did extremely well, controversial subjects, and they analyzed the studies very well. Dr. Upali told us about the limitations of the study, a huge study, but with negative results and all that thing. But I think it needs further, as she said clearly. And we learned about the management of chronic stable angina, which I think is very useful for the general practitioners. And I think I'm glad that he emphasized a lot on the lifestyle management and also talked about the medical management and all that thing. There are many drugs which are not available in the United States. I think we can add that up. One of them is trimethoprim, other is nicotindil, which they do mention occasionally, which is also extremely useful under our setup. And we have seen that nicotindil possibly is even better than nitrate, does not develop any resistance, and it has also effect on the sort of preconditioning and so on and so forth. So I think those guidelines are extremely good, but we have to keep that there are other drugs available which could be very useful. And he talked about when to intervene and so on. I think that was extremely good. Earlier, where people have also talked about this, that when to do the angioplasty, etc. And I would agree, as Jacob also said, that it's limited cases which can be on medical therapy. There's a lot of overlap, but angioplasty possibly will be good in those patients who are not, those select patients which were there in those studies and all that thing. And finally, I think the intravenous iron came with a bang. You are giving to almost all patients. Now it's controversial, but again, very limitation of the study. You know, during the COVID, it was interrupted for several years, and then the patients fought back and so on. So again, a very sort of study with a lot of limitations and all. But it shows that we have to have a moderate view. We can't say that the mortality will be increased, but the quality of life possibly. And I think our patients are iron deficient, so I think we should continue using. As you said, can we use oral? Although there's no data, but I think once you have corrected with intravenous iron, the iron stores, etc., then one can continue. At least I do continue this patient on this oral. I think we'd like to thank again all the speakers and all the moderators for doing this excellent job. And I think I learned a lot, as Jamal said, from each one of the presenters. And I think I'm sure the clinicians would have learned also a lot. And there are several tips given which they can use in their clinical practice, because textbooks really bring these studies after a lot of time. And therefore, I think the latest up-to-date sort of information was very important. And it was such a huge conference. And I think the speakers and the moderators have really done a great job in making it brief and giving the message from the Indian cortex to the Indian clinicians. Thank you very much once again. And thanks a lot again to all the speakers and moderators. Over to
Thank you so much, sir.
Thank you, sir. Thank you.
Thank you so much, sir. And sir, on behalf of Corona Remedies, I, Tushar Tuhi, take this opportunity to thank Dr. Professor S.C. Manchanda, sir, Dr. Subhash Chandra, sir, Dr. Nilesh Gautam, sir, Dr. Arun Srinivas, sir, Dr. Sunip Banerjee, sir, Dr. Jay Shankar, sir, Dr. Kamal Sharma, sir, Dr. C.K. Ponde, sir, Dr. Professor Soumitra Kumar, sir, Dr. Jay Gopal, sir, Dr. Rupali Khanna, madam, Dr. Pankaj Jariwala, sir, and Dr. Purnanand, sir, and all esteemed delegates. Thank you for gracing Deciphering ACC and interpreting the content from Indian perspective. These high-end scientific programs reflects the commitment of Corona Remedies towards improvement in diabetes, awareness, diagnosis, treatment, therapy adherence, and compliance to medicine to improve patient outcomes. We are sure that from today's program, our esteemed delegates must have picked clinical pearls. I also extend my sincere thanks to entire sales and marketing team of Corona Remedies for making today's Deciphering ACC a well-orchestrated program. With this, we shall end today's insightful session. Thank you, everyone.
Thank you.